Good morning, everybody. Welcome to our Roundtable 3, our last and final roundtable on non-emergency health transportation. We are here in Annapolis at the Maryland Department of Agriculture. My name is Yolanda Hipsky, and I will be joined by Leslie Cokers soon. But right now, I'd like to take this moment, if we could introduce ourselves. Please say your name, what region you're from, and your organization. And sir, if you could start.
I'm Bill Murphy. I'm the Executive Director of Friends of Disabled Veterans in Carroll County. And we've been in existence now, this is our 6th year. And we provide non-emergency medical and dental transportation for veterans in Carroll County, Frederick County, Adams County in Pennsylvania. And we take we'll take them as far, our veterans, as far as Washington, D.C., Lebanon, VA up in Pennsylvania, so about 120 miles apart. Thank you.
Hi, I'm Lorena DeLeon. I'm the Senior Director of Population Health and Social Determinants for Maryland Physicians Care. Maryland's Physicians Care is the 3rd largest managed care organization for Medicaid in the state of Maryland. We have the privilege of serving about 251,000 members statewide.
Good morning, everyone. My name is Mitchell Wolf, and I'm Director of Sales at a technology company called TripSpark. And our transportation management platform is used in, I think, 3 different counties in Maryland. Our sister company transportation platforms are used in several more. So we've been in this state for a very long time, as well as across the U.S.
Good morning, everyone. My name is Sarah Seitz. I'm Director of the Maryland State Office of Rural Health. I also oversee the work of the Office of Healthcare Workforce Development, and we're based at the Maryland Department of Health.
Good morning. I'm Charlotte Davis. I'm Executive Director of the Rural Maryland Council. So welcome to the Maryland Department of Agriculture. We are housed here. In fact, our office is just across the hall. So welcome to MDA, and thank you all for participating today.
Good morning. My name is Sharon Smith. I am the Director of Transportation for Partners in Care Maryland. We are a nonprofit based in Pasadena, and we work with older adults ages 60 and older. Our mission is to help them be able to age in place in their own homes. And by doing so, we provide services like transportation, handyman, member care, across the board. We're also a 5310 grant recipient, so we have 5 lift-equipped vehicles that we also provide as well. Just full disclosure, I'm sort of getting over bronchitis, so if you hear me coughing, that's what it is. It's not anything else. So thank you.
Hello, I'm Mika Robinson. I oversee the Health Equity Division at the Calvert County Health Department. And we currently have a program called Highway to Health, where we partner with Lifestyles to get people transported to food pantries and appointments in and out of the county for those who don't qualify for Medicaid transport.
Hi, my name is Candace Smith. I'm the chronic disease nurse at Calvert County Health Department, and I'm also the lead nurse on the Highway to Health program, like Mika just spoke of.
Good morning, Andrew Weil, Director, Shore Transit, a division of the Tri-County Council for the Lower Eastern Shore of Maryland, representing Worcester, Somerset, and Wycomico counties.
Scott Warner, I'm Executive Director of the Midshore Regional Council. We cover Caroline, Dorchester, and Talbot counties, but we also administer the Maryland Upper Shore Transit Coordination Program, which covers not only our 3 counties, but also Kent and Queen Anne. So we work with Delmarva Community Transit and Queen Anne County Ride.
Good morning, everyone. I'm Jonathan Dayton, the Executive Director of the Maryland Rural Health Association. I live in Allegheny County, and I would be remiss if I don't mention that today is National Rural Health Day. So lots going on today.
Good morning, everyone. My name is Felicia Green. I'm the Medical Assistance Transportation Supervisor within the Wycomico County Health Department.
Good morning. Dawson Hunter, whoa, it was loud. It's just right there. I'm with Kent County, Maryland, and they've got me doing transportation housing issues. Actually very kind of timely. I attended session 1. I was unable to attend session 2, but I'm in kind of discussions about non-emergency medical transportation with the University of Maryland Shore Hospital in Chestertown, and they want us to help kind of figure out that conundrum. So please tell me what to do. Thank you.
No, he's handing the microphone. Oh, did we
Do
get?
They juggled them around.
Oh, I'm sorry. I apologize. I stepped away. My name is Nancy Fields. I like to say Nancy Jean Fields. Thanks, Mom and Dad. At any rate, I work for FDVCC, which is, to my left here, is my boss, my mentor, my buddy. I am his assistant director. We are, FDVCC stands for Friends of Disabled Vets in Carroll County. Let me tell you, we go everywhere. Obviously, I'm in Annapolis today. I was in West Virginia the other day. We take for non-emergency transport and doctors, hospitals, x-rays, oh gosh, whatever the medical need is, we're there to help them out. It's a free service, and we graciously accept any donations, be it money or all kinds of funny things we get. But it's all great, and the people are amazing. To me, vets are the most forgotten group and should have never been. So this is my tiny way to help. And my dad, rest in peace, he'd be proud. So that's who I am. Sorry, I missed the introduction. Can you turn this thing off?
Okay, so did we get everybody who's in the room? Except for, okay, so let's start with the folks who are online. I'll call out the names. If you could introduce yourself, say where you're from and your organization. The first person I see is Simmons 1.
It's Marshall Simmons. Good morning, everyone. And I'm from Baltimore County, and I'm the general manager for Baltimore County Ride. So we provide paratransit, on-demand response transportation in that whole region. Thanks. I'm glad I'm here this morning.
And then we have telephone, we have Jay Pelton. Or Pelton Jay. They might be able to call in. I also have 410-778-7025.
Hi, yes, my name is Sally Coleman. I'm with the Kent County Health Department, and I work with the Medical Assistance Transportation Program. And I also in the room with me is Crystal Arzola, and she also works here with me.
Okay, great. We have also Jay Mickey.
Yes, good morning. My name is Jada Mickey. I work for Maryland Department of Health in the NEMT program.
Great, thank you very much. We have A. Levine.
Good morning. My name is Andrea Levine. I'm a health policy analyst at the Maryland Department of Health in the Division of Community Support Services.
Okay. Okay, we also have Angelica Daniel.
Good morning, everyone. My name is Angelica Daniel. I'm from Baltimore County Department of Transportation, and I work alongside Marshall Simmons.
Okay, we also have Chris, Carroll Tech and Innovation Council.
Yeah, good morning. Happy to be here for our third roundtable, and happy to see that more people from Carroll County have joined us. Hello to my friends from Carroll County. Sorry I couldn't be there live today. I'm Chris, the Executive Director of Carroll Tech and Innovation Council.
Okay, great. This is fantastic. We also have Darlene Valentine.
Hi, Darlene Valentine, Patient Access Manager, Family Healthcare of Hagerstown. And I have Laura Pennington with me, which is our outreach worker.
And we have, great, that's great. Welcome, welcome. We have Crystal Arzola.
Hi, good morning. I am with the Kent County Health Department's Maryland Medicaid Transportation from Kent County.
Excellent. We're having great coverage from a lot of folks. We also have a Delegate Robin Lewis. Delegate Lewis, I think you might be on mute.
You're right. Thank you. So thank you guys. It's great to be with you. I'm Delegate Robin Lewis. I represent the 46th Legislative District that's located in Baltimore City. This is my second meeting. I attended the first, most of the first meeting, and I'm glad to be here for this final meeting. I'd like to remark that I think I might be the only elected official on this call. And it's worth mentioning as well that I serve on the House Health and Government Operations Committee. That is the committee in the House of Delegates that oversees health policy. So the work that this group will do is very relevant to issues that I have jurisdiction over. In addition, I'll mention that I'm also the only member of the Maryland General Assembly who is car-free. I depend on transit and other modes to get around, and I do a lot of policy work as well on transit, mobility, and accessibility. So this topic is really important to me, and I'm glad to join you and hope to get some good work done. Thank you.
Awesome. We welcome aboard, and we look forward to the conversation. Elizabeth Beck.
Hi, everyone. I'm Elizabeth Beck. I'm a program manager with Montgomery County, working in Department of Health and Human Services.
Welcome, welcome aboard, Elizabeth. And we're glad to hear you here. We also have Heather Agualo. I apologize if I pronounced the name.
Hi, good morning. My name is Heather Aqualo. I am the Mobility Manager at Allegheny County HRDC. Currently, we are serving a little over 4,300 people from the county of Allegheny County for non-emergency medical transportation from the ages of birth and up.
Great. Welcome, welcome aboard. We also have Jeanette Jeffrey.
Hi all, my name is Jeanette Jeffrey, and I'm the health educator with the Rural Healthcare Transformation Team at University of Maryland Shore Regional Health in Chestertown, and just had a meeting yesterday with Dawson Hunter, so thanks for the big shout out, Dawson.
Great, welcome, welcome aboard. We also have Jay Mickey.
I already introduced myself, but I'll do it again. I'm Jada Mickey. I work for Maryland Department of Health with the Non-Emergency Transportation Division.
My apologies that we have a lot of folks who are joining us.
No problem.
We also have John DeKluski.
Good morning, everybody. I'm John DeKluski. I'm with the Transportation Association of Maryland. And sorry, I can't be there in person today.
We are too. Okay, great. We have Lisa Short.
Good morning. I'm Lisa Short. I'm Midshore Behavioral Health. I'm a behavioral health coordinator for adult services for the Midshore area.
Great. Welcome, welcome aboard. We also have Mike Hill.
Whoops. Sorry, guys. There we go. Trying to get the right buttons there. I'm Mike Hill, the director of Garrett Transit Service with Garrett County Community Action. We do the NEMT program for Garrett County.
Great, welcome aboard. We were just in western part of the state last time.
Yeah, I didn't make it down to that. I almost tried, or I tried to, but had a couple other meetings. But I've been online for all three of these. So thanks for everything.
Awesome. We also have Noelle Flaherty.
Good morning. This is Noelle. I'm the Director of Case Management at Calvert Health. Sorry, I can't be there. I had to get my HVAC replaced today, sadly. I'm a referral source for the Wheels to Wellness program, and I work closely with Yolanda. So this is a program where health transportation is provided to people in the community setting. So this is not discharge from the hospital. These are folks who are not eligible for Medicaid transport or cannot access the available transport and need assistance getting to their doctor's appointments or dialysis.
Awesome, great. And welcome aboard. Glad to see you here, and good luck with that furnace. It always seems the first day of summertime and the air conditioning blows, and the first couple of days of winter, when it gets cold, the heater goes. We also have Renee Nicely.
Nicely. Yep. This is Renee Nisley. I'm the executive director of the local management board in Allegheny County.
Great. We were at the western part of the state just last month. So welcome aboard.
Thank you.
We also have Rob Shearman.
Hi guys, almost last but not least, I say. Rob Shearman, Ocean City, Maryland Transportation. You might think of us as a service for vacationers, but outside of the summer months, we do have 7,000 year-round residents. And in addition to our fixed route service, we do offer a medical transport service to our permanent residents who are ADA qualified. So happy to be here.
Awesome. Great. Welcome aboard. Great to see y'all here. And we have also S. Danishpour. I apologize for the name.
That's okay. Hi, good morning. My name is Sarah Danishpour. I am with the Maryland Department of Health. A few of my team members have already introduced themselves, but my division oversees the Medicaid NEMT program. So thanks for inviting us to be here today.
Thank you for being here. I received some information from about the transportation program that you have. Welcome aboard. Also, we have Rob Shearman. Did I already?
Yeah, I just went.
Sorry. Yeah. Okay. Is there anybody else that I missed that's online? A couple folks in the room. Yeah. And then there's a couple of folks, new faces.
Hi, I'm Sam Sneed. I'm the Director of Transportation for Anne Arundel County. Sam Sneed, I'm the Director of Transportation for Anne Arundel County.
Great, welcome. Well,
I'm Courtney Thomas Winterberg. I'm the Director of the Department of Social Services in Allegheny County, and I chair a transportation work group for our Chamber of Commerce around transportation for all.
awesome, welcome everybody. Has everyone had a chance to introduce themselves? We have a pretty good sized group here. Okay, so I won't take too long because today is our third and final roundtable meeting that we plan on holding. At our first meeting, we reviewed our current programs and try to define what we meant by non-emergency transportation. At our second meeting, we focused on 3 recurring themes and presented some supporting statements for each area. And today we're hoping to identify some potential strategies that could better help and address the non-emergency medical transportation problem. So at the previous meetings, I had mentioned, Wayne County, Indiana, had transformed their education when they began transporting kids to the school kids to the schools. And that was a paradigm shift that became what we know as the modern day school bus. And it changed education. And today we're talking about a different type of paradigm shift, and that is to ensure that, and for example, we know that there is a lot of social determinants that affect healthcare, such as and the health outcomes of a community, and so we're talking about trying to address that, and but we're trying to address it by ensuring that there is equitable and reliable transportation, and if for our most vulnerable citizens, and if we can improve their health outcomes, not only for them, but it will also change the health outcomes for the entire community. And that's what we're trying to do. We're talking about trying to bring equity to healthcare by expanding transportation, and this is about providing, also about saving health dollars through the maintenance of preventative care. So at our first roundtable meeting, there was 3 primary focus areas that we talked about: coordination, industry characteristics, and unique community member challenges. And based on the comments we heard at the second meeting, we presented 3 statements. The first one related to coordination was that there is a lack of diversity in funding and needs related to transportation that makes coordination challenging between healthcare and transportation providers. For industry characteristics, we had presented the statement that since socio and economic status is connected to health, and since demand exceeds services provided by social welfare, transit, and healthcare, characteristics for each industry should be evaluated. And for the third and final focus area, unique community member challenges, we presented that the non-emergency health transportation provides unique community member challenges, and coordination is critical for effective services. So here's a real brief, here's our agenda for today. I promise that we will get you out of here by 2:30. And we have already done the welcome and introductions and an overview of the roundtable 1 and 2. And we will continue on with today's goals. Today's goal is to get feedback about possible statewide or regional level transportation solutions. And what we're hoping to do is identify 2 to 3 policy statements to support that. So I'm going to play a quick vignette.
So hi, I'm Elaine Heiko, Executive Director of Vermont Public Transportation Association. Here, excited to talk to you today about Vermont's elderly persons with disability transportation program. So that program is administered through Vermont's Department of Transportation to address unmet needs, increase transportation options, enhance efficiencies, and provide the most effective service we can. E&D plays a vital role filling gaps in the existing transportation services for older Vermonters aged 60 plus and individuals with disabilities. Because Vermont has a small population of under 700,000 residents, we consider ourselves a rural state. However, we invest heavily to provide on-demand services to fellow Vermonters living in rural areas to ensure positive health outcomes and reduce social isolation. The E&D program is a coordinated approach to meet the needs of Vermonters who mass public transportation is unavailable, insufficient, or inappropriate. Our approach is to increase access to transportation services through the E&D program. E&D is really a supplementary transportation program that is an integral component of our transportation system here in Vermont. Vermont's unique as all of our local transportation providers serve as the regional transportation brokers for the E&D program and for non-emergency medical transportation for Medicaid, thus allowing us to provide statewide coordinated services throughout Vermont and offering both statewide service and efficiency. Vermont's regional public transportation providers work with human service agencies, partner to coordinate the E&D trips along with non-emergency medical transportation trips provided through Medicaid, other funding sources, and the public transportation system. This coordinated transportation approach extends the impacts of the available E&D funding as the regional brokers utilize multiple funding sources to fill capacity on our vehicles and maximize the program dollars. They work together to plan and coordinate with their area partners, including their regional planning commissions, human service agencies, and other community organizations and passengers to define their grant applications for the needed service in each one of their regions. So in other words, the regional programs through E&D look a little different throughout the state based on what those needs are defined as with all their community partners, including their passengers. They also have an option to subcontract with other community organizations to provide some of their services if needed. In Vermont, we invest a robust $5.1 million of federal dollars into our E&D program with a 20% local match that includes both cash and in-kind. Those trips include medical trips not covered by Medicaid, shopping trips, and social trips. Often too, personal trips in some regions are allowed whenever capacity allows. In all areas, medical appointments are prioritized, especially critical care. So thanks for taking the time to discuss our elder persons and disability transportation program in Vermont, and feel free to reach out and contact us with any questions you may have.
Okay, great. The reason that clip shows how they do things in Vermont, and I'm not necessarily saying that we should consider transplanting Vermont into Maryland, because we're not, but it does show a good it does show how the state coordinates their activities amongst the healthcare as well as transportation. It also shows somehow they address some of the unique industry characteristics, and they also show how they meet the patient needs to make sure that the patients are met as well. And I think that because of those three items that are shown in that clip, that's why I thought it would be a good segue to our discussion today.
So hi.
Oops, wrong one.
So hi.
There we go. Sorry about that. Okay, so as I said last time, we had three primary focus areas, and the first one we looked at was coordination. And at the last meeting, we presented that a statement that we felt captured the first meeting, the comments we heard from the first meeting, and that is that there is a diversity of funding and needs related to transportation that makes coordination challenging between the healthcare and transportation providers. We presented that, and in that conversation, we identified three primary issues here. Number one, there is no single location or there's no single phone number for information. I've done some research. We have now Maryland 211, which I think is starting to come up and to address community services, and that might be something we may want to look into. The second issue we heard was that there's more coordination is needed at the regional and state level. There are 5 regional coordinating bodies, which I'm one of them. I think Andrew, you're one of them, and Scott, you're another one. So we have 3. There's no one else here, right? Online, there's a regional coordinating body. So we have 3 out of the 5 here, and there's also the MPOs are also identified, the Metropolitan Planning Organizations. Those are regional resources that could work better with the state organizations agencies to help address non-emergency medical transportation. And finally, the third issue that was identified was that communication and coordination are both needed between healthcare, public health, and transportation resources to support community members who don't have access to reliable transportation. And some of the things we heard was in the mountains, there may not be internet service. There may be some challenges with literacy and things like that. So we needed to reach out to those folks as well. So based on that, we came up with 2 possible solutions. The first one was develop state and regional coordination methods, and the second one is develop a statewide contact point to direct constituents to resources. Those were our two focus areas. And at this stage, I just want to see, does anyone have any comments on either of these ideas?
Yes, sir. There you go, Hunter. All right, now I have this thing. Well, I think you mentioned 211. I think that's to your bullet point number 2, that currently exists, but it really only, it's an effective system and solution, but it's only good as those providing input into that system, letting them know of their services. I think there's a 211 call center. We're on the Eastern Shore, so there's a 211 call center in Salisbury, which definitely benefits us. I know that they expanded from having a Baltimore focus, so we're thankful we have something on the Eastern Shore. But you have to remind folks to engage with 211 directly so that their services are appropriately listed there. And that's the biggest challenge. I'll just stop there, but I think point 1 is great.
I'd just like to add that from my initial observation and reading through the documents coming to today's meeting, while these pain points are very, very real and challenging to address, they're not unique across the country. So everyone here is, from a particular area and organization and knows those details and nuances so much better than I do. But what I can bring to the table is an understanding of what it looks like in Vermont or Minnesota or Florida or Texas. And they're similar but different. So I want to be very respectful to know that it is very, every state and local county can be very unique. But stepping up a bit, it's interesting to think about what one might need in support of delivering services to rural communities as well as urban centers, to underserved populations, to older citizens and community members, and trying to understand that we, in the reality is there's a dollar crunch, and how do we coordinate that? So before I jump to a 211, that's part of a solution and a good resource that can be helpful in this local community. But I kind of think we can take it up a level and say, well, what do we want it to look like? How do we break silos down between transit and paratransit and NEMT and university and economic development? Fundamentally, we have a challenge of transportation capacity.
So I just want to comment on the 211. For us as a health plan, it's a difficult resource, right? Because we can't aggregate any type of health outcome from a platform like that. Nor do we have insight as to who's been serviced and who hasn't been serviced, right? So although they can provide some information, it really doesn't guarantee that there's going to be a closed loop if we refer somebody in, and that we're even going to know any of the outcomes as a result. So it's not a viable solution, I would say, from a Medicaid perspective, in my opinion.
One of the things to consider, and I know I'm coming late to these meetings, but other than 211, what I've heard from our travel audience and others is a clamoring for more travel training to come back, in person, video, pamphlet, just to educate people, because people were kind of holed up for the last couple years, and they need to learn about what our transit systems provide, what our on-demand systems provide. There may have been wholesale changes to one of your systems, and you want to educate people as to how much it costs if there's a fare, if it's fare-free, if there's on-demand in an area that's available, or if there's some sort of elderly or disabled service. So those are the kind of in-person trainings or video trainings or pamphlet trainings that really need to get out there, and they can come through a lot of different avenues. One could be through your MPO, and another could be through the DOT. It could be through your healthcare provider. But having that source to really train people how to use transit would, I think, make a big difference other than a centralized line. The line could link them to the travel training and educate them as well.
I would suggest that 211 is a fine resource, but if you want to solve the immediate problem, you need not even a warm handoff, but a direct link. And I think that every single spot in the resource, call this number, is a fail point. I think if you want to make a meaningful change, you must do regional coordination that has subject matter experts, that one call does it all. Forgive the cliches, but you get the point. I don't call the hospital to get a doctor's appointment. I call the doctor's office. Call the doctor's office doesn't do any good for transportation, but if you call one person who's linked with all that can understand the schedules in the physician's offices, understand the transportation networks, understand the links between first mile, last mile, finding the appropriate mode of transportation, opportunities for funding, and the whole thing. And that, to me, involves, in my rural area, which sounds very much like Vermont, looks different around the state, but it's based on the individual region's needs. It allows us to connect to what's available, and it really needs that subject matter expertise, because if you ask me to go to Garrett County and tell you how transportation works there, like, I'm just happy that Google gets me not running off a hill. So I encourage that we aim small, miss small. State level coordination in a state that is so completely different, not relatable at all, but yet diverse and needs to be connected. We start at the bottom. The doctor's office, the dialysis center, the healthcare system, the local transport companies and regional transport, and interconnecting into places where we can shrink our healthcare network by getting people from rural areas into urban areas where the greatest healthcare systems in the world exist. We just have to figure out how to get that last mile, one more cliche.
So Andrew, I would echo what you've said. That's part of the reason why our strategy around social determinants has been to break Maryland down into 5 regions for our own population and at MPC. And I actually invited Mitchell to come from TripSpark because they've solved for this in many other states. And this is actually a point of discussion that we're looking at in Allegheny County. And this is the vendor. And I don't know if we have time to share that list, but if you could see all the different accounts that are already using this platform in the state of Maryland, to your point, all they need to do is be interconnected. And that would solve a lot of the problems. So thank you.
Yolanda, if I can step in here, and he mentioned us up here in Garrett County. So if I can just touch on that a minute too. And I know Dwayne Yoder was on these other 2 roundtables. He's not on here today, I don't believe, but through our community action up here, and everybody probably aware that he does a lot through the state involving this, or, in regards to medical transportation. But I know he said it the last time, and kind of touching on what you guys say, at least up here for us, and I think maybe in a lot of the rural areas, the regional and certainly the statewide coordination just makes it very difficult for our residents up here. We just got the NEMT contract back in July, and I might have, we might have touched on this in another meeting, but for almost 2 years, it was ran by an agency out of Catonsville for Garrett County. And I can tell you from the stories we heard, we weren't directly involved in it, obviously, because they had the contract, but it was a nightmare. No offense to anyone down, at their agency or anything, but they didn't know Garrett County. They didn't know the area. They didn't know where they were going for the doctor appointments. They didn't, know where they were picking up people. So now that it's came back since July, our point of contact, we get a lot of calls here for NEMT, but our point of contact is the health department. And I assume, I don't know this, but I thought each county, although I do remember they kind of went regional, but our county has, they handle all of the NEMT registration, eligibility. They make the appointments. Then they send us a list to see what we can do and, see how many of the transports we can actually do. So just speaking for us up here, that works so much better than if we would go even a regional thing for us. That includes probably down to Frederick, I would guess. And again, they're not going to know, a whole lot about what's going on. It seems like a lot of you spoke that we, don't know what's going on up here in Garrett County. And it is our own little, situation up here. So speaking just for us, and I know Dwayne touched on this before, the direct contact almost county-wide, we feel works the best.
Can I
Thank you.
Oh, thank you. Can I talk or no? Oh.
I was just going to ask, because I definitely agree with you, and there's been a lot of discussions about how we can better coordinate in Allegheny County, specifically with the utilization of technology sort of as that backbone with our health and human service agencies and public transit. But I guess as we go back to these two potential solutions, where are we in terms of context with what's happening with non-emergency medical transportation and the RFP that was released at the state? Because I believe it closed November 2nd, but they are looking for a single point of access, at least with the statewide call number, eligibility screening, and coordination of appointments. They won't be providing the transportation locally, but they are looking at it's no longer being housed at the local health departments, but as a statewide vendor. So I think that's important to keep in mind as we discuss potential solutions and recommendations.
And I'd mentioned that that's just one component of the conversations that we've been having. So that's specific to Medicaid paid transportation. And I'm hearing what we probably have several policy statements just within this focus area of what kind of coordination is necessary at a state level, what makes sense regional. I hear things like technical assistance, potentially development of transportation literacy kind of documentation. And then at the local level is the real transportation provision kind of happening and knowing who needs to go uphill both ways in the middle of winter to get to that address, those kinds of things. So I think we have a few items coming out of here.
Oh, hi, good morning. My name is Nancy, as I said earlier, and I work with Friends of Disabled Vets in Carroll County. So our focus is the vets. Bill Murphy has created an awesome venue where we take and transport for non-emergency medical. It's extremely successful. I'm very proud to be a part of this group. You talk about, and as you said, a statewide thing, that's awesome, but that statewide needs to address Ocean City, address the small little Pocomoke City, Allegheny County. Hello, there's like they mentioned the rural areas. We are housed in Carroll County. However, let me tell you, I've been to West Virginia, I've been, Martinsburg, as I said, we do focus on the the veterans. And with respect, let me tell you, you learn real fast, that initial thing that somebody was mentioning as far as training and knowing the routes and knowing this stuff. What's wrong with modern technology called the Garmin? Not that hard. I've transported wheelchair. I've people that are still, bless their hearts, ambulatory, they're missing limbs. All kinds of situations, but nevertheless, Bill Murphy, please address him. He's got wonderful ideas. As I said, our program is extremely successful. I actually do all the coordinating for the rides. And let me tell you, we get them there, we get them there on time. Yeah, I've been all over the state, Pennsylvania, Maryland, DC, West Virginia now, I just added. And so we do go to people's homes and stuff and take them, deliver them. And you talk about doctors, radiologists, pathologists, hospitals, been everywhere. At any rate, he has managed to create our own little world. And yes, it is to the vets. It is nonprofit. We do not charge. But the wonderful thing about it, the communication in the center of point is, hi, my little card. You call us. I coordinate it. I pick you up. Oh, I or myself, or I coordinate a driver. The driver calls them the night before, picks them up, takes them to their appointment, and takes them home. It's pretty darn good. And I have gotten nothing but incredible people, and the gratitude is amazing. When you talk about 211, okay, that coordination needs to identify each of these counties that are definitely remote. As they say, Maryland is unique. Okay, I'm kind of a weirdo. I love to drive in the snow. You ain't gonna tell me I can't do it. I do. Yeah, here's the funny part. I'm volunteer and I love it. But this is very, very important to be able to cover everywhere. Those remote rural areas should not be ignored for anybody of any disability, race, creed, color. I really don't give a peanuts. You know, they need a ride. They need someone that greets them, gets them in their vehicle, gets them safely to their appointment, and brings them home. It's really not that complex. Of course, Bill might say differently because he's been doing this for 7 years and I've only been with him since June. He loves me. But the communication is one thing, but the other thing is that coordination and education. I can't tell you, I have gone around with vets. I go into different legions. I go to the VFWs. I put out a little card that says thank you, and it's thank you to the vets. Hello, this service is available to you. You'd be surprised how many of them go, huh? I'm like, what? Why are you missing this? What are you missing? Fortunately, in Carroll County, we do have VIP. What does VIP stand for? Veterans Independence Project. Okay, Veterans Independence Project. I found out my little card went out to a whole bunch of homeless people. That was really funny, but you know what? They needed help. I was really blessed when I ended up getting 6 phone calls. I was a little bit startled, but it all worked out good. They needed medical help. That was the bottom line. Take them, get to their appointment, and get them back home. Not that complex. And I think 211 could be developed by county. And I say that specifically because a couple addresses about the ruralness and what have you, because this is one unique state. Because we got from the water, and we literally encompass America. Thank you, Trump. So that's all I have to say.
I'm Bill Murphy. I'm the Executive Director of Friends of Disabled Veterans in Carroll County. We've been a 501c3 for the last 6 years. And in that time, no government money was ever involved in it. We've raised over $312,000 in the last 6 years. What we do is, as Nancy just talked about, we're non-emergency transportation for veterans in Carroll County. And now we've expanded to Frederick County. And we're also up in Adams County, Pennsylvania. We have 5 vans. They're all paid for. And we're so excited to be able to offer this service to our veterans. I've been asked, I'm a public speaker. I've been asked to, we gave a presentation to the Frederick County Veterans Advisory Council. We're going to be going in very areas throughout, like North Carolina. We've been asked to present the program down there. And it's the idea that's, I think it's unique in the state of Maryland. I don't think there's any other private organization. And with all due respect to the government, I think the best thing to do is for a private individual like myself that started it up. They said, well, what we need out here in Frederick, we need a Bill Murphy that basically has an idea. Take that idea and run with it. The need is out there and it's greater every day. The problem that we had in the last 2 years was the epidemic, with the pandemic, with the COVID-19. for the first year, we didn't do anything, but in the second year, we went out and we worked every day. We've lost in the last year over 15 veterans that died because of COVID. And it's a national problem because whether you know it or not, our longevity rate decreased 1 year in the last 2 years because of COVID. And the need for services that we providing this free transportation service is unique, not only to Carroll County, but all throughout the United States, because our average of veteran is probably about 62 years, 62, 65, and it's the Vietnam era veteran that have a lot of issues with cancers, with Agent Orange disease, and they're not getting the care. What hurts me the most is when I get a call, for example, like Baltimore City, that the gentleman needed to go for dialysis care 3 days a week, and it's 4 hours a day. It's hell. Okay, I've worked with these patients for a number of years. Unfortunately, we're not in a position to give these long-term appointments to the veterans, and I'm sure you see all you shaking your head, they're the same thing. Last week, I had one call that was fill up and have the grace. It was a veteran, and he needed to get radiology treatment. So I think if there's a way that that we can go out and do this in a private situation instead of with the government. The government is great, but that one gentleman that was talking about the problem that they had in his county, taking for somebody from Catonsville to understand what's going on out in that rural county, they're not going to do it. There's no way that it's going to work out because the government, it's too big, but you can handle it on a case-by-case basis in your various counties throughout the state of Maryland. And I'm very, very gracious. You know, we don't take any money at all. All the money that we collect, it goes back into our organization. And recently, 3 weeks ago, we were recognized. They recognized me for my work with the veterans as the outstanding philanthropist of the year for Carroll County. That's out of 324 different nonprofits in Carroll County. And if I could do that, there's other people. And I just thank God for somebody like Nancy Fields here that's taken all the work off of me with scheduling and all this. But the possibility to do this is out there. And I'm talking to a lot of people about getting grant funding, because what we're doing right now, we're expanding, and it's going at a very, very large rate. And I'm confident that every veteran that we save out there, this is just for veterans, but for the civilian side of it as well, there's a great need out there all over. But if we be more positive about it, you know, here today, you hear all the negativity. And I'm a positive person. I'm a public speaker, been doing it for over 20 years. And I think we need to get a general consensus of being more positive in this country rather than listen to all the negativity that we have out there. Do you have any questions, anything I said?
How many trips do you do a month?
We're looking at about 35 trips a month, or more, you know, Nancy was saying more. So every day it's just a challenge. And the greatest challenge that we have is this longer range. Right now at the VA, unfortunately, when you want to get a pension and compensation, they'll send you as far away as 120 miles, which we turn around and we'll take them up there. My brother needed a set of hearing aids. Well, he lives up in Hanover, Pennsylvania. We had to take him over to York in Pennsylvania to be able to get the hearing aids for him. And there's a lot of veterans that are over 65 years old that really need a lot of help out there. And unfortunately, they're not getting it from the VA. God bless the VA, they're trying to do everything. But a lot of times what they're doing now, like right now, my right eye, I got a cataract. I've been trying for about 4 months to get an appointment. And a lot of times they'll come up and say, well, we don't have anybody there to be able to take care of you. So hopefully, not to say that they're not doing a great job, but they're overwhelmed right now and they need help. And we're working with the VA. I do this on a daily basis, and I just don't like to turn somebody down. But Nancy here took the same veteran down to Green Street in Baltimore City at a 9 o'clock appointment. When she got there, not one time, but twice, the appointment was canceled. And then Nancy said, well, when did you call? And they said 7 o'clock in the morning. And she was already on her way. And by the time she gets down there, and that's not acceptable. Mm-hmm. And I think the people in the United States got to realize, you know, we got to do the best with the little limited funding that we have right now. And that's also for the government and for the private industry as well. And years ago, it used to be that the churches would get involved with. So we're involved with a lot of churches as far as fundraising and help. And not only do we provide what Nancy talked about and I talked about, but we also provide power chairs, scooters. We provide hospital beds, ramps, and any durable medical goods that are like that. And we don't like to turn them down, but we have a large quantity of durable medical goods that I've talked about here that we donate to our veterans out there and sometimes non-veterans. And everything right now, if you realize it or not, for example, like the batteries for these mobility carts, you know, the wagons, the prices have gone up 100%. You go into your local food store, you'll see with the inflation that's out there today, it's going up dramatically. Thank you.
Thank you. And I just want to pause for a moment. As Yolanda already indicated earlier, my name is Leslie Coker, so I am going to be helping by facilitating the remainder of this roundtable meeting. We're going to take a couple of more comments and then also check to make sure that folks online have not been looked over. And then we're going to talk about, you know, after thinking about a lot of the different challenges and unique circumstances that maybe a statewide coordination method might not be able to address, we'll talk about some alternatives that we could think about and consider as we move forward. And so I see this woman has a comment, and I'm going to check online now.
So good morning again. I'm Sharon Smith with Partners in Care Transportation. I've been working in public transportation for more than 30 years. I was 5 when I started. And so, you know, a lot of good comments around the table. And I think one of the first things we need to do, and Sam kind of touched on it, is sort of the education process of who's out there. There's so many providers. This gentleman just talked about their program. There are public transportation providers, there are nonprofits. We need to know all of the systems that are out there, what they do, how they do it, what their eligibility criteria is. You know, if I live in Howard County and I need to get to Baltimore City to Hopkins for a specialty appointment, and I don't drive, and I don't have anybody to take me, and I'm over the age of 60, how do I go about doing it? Well, one of the things is, if I'm eligible for ADA service, potentially I can get a ride to Arundel Mills, and then from there, get the RTA into Baltimore City, depending on the time frame of when my appointment is, because if I'm beyond a certain point, they may say, I can take you, but I can't bring you back. And so in order to have that real connectivity, we need to know who all the players are. Once we know who all the players are, then we can identify the appropriate methods of being able to coordinate all of those services, so we're not duplicating, but making sure that we're providing services to all the people who need it.
Thank you. Is there anyone online who has not had an opportunity to comment? Because I don't see any hands raised, but if you do want to ask a question or comment, please unmute yourself and speak or raise your hand. Anyone else in the room?
So I just have one thing that we recently learned in Calvert County that I didn't understand was we have our transit system is not a bus system, it is a flag system. So there are not particular stops. So what happens is many of our residents are denied Medicaid transport because they're so close to a bus stop, because there's really no specific bus stop. So for instance, if they're going into neighborhoods, every street may be listed, so you would be very close to a bus stop. The bus may not stop, but you know that the bus comes at a certain time and you are to flag it to pick you up. And then of course, like someone mentioned, you know, with our program, even though we partner with Lifestyles to help get people to places, and we use grant funding, for people who have like dialysis, the money would run out so quickly if we pay for every single transport for these people to get dialysis. And as you know, dialysis, it really just puts a toll on people after a while. So you want to service this community, but they can't even use their Medicaid transport because their street is listed on the flag system. And it doesn't matter, you know, they have that inability to, maybe they can get to the bus stop before dialysis, but afterwards they're probably so tired. How do they get back home from the bus stop? So, you know, we are just trying to figure that out too, because obviously it's not enough money to just pay for every single dialysis patient to get to and from dialysis, but you know, what do you do? And especially when you have flag transit systems and every single street is listed in the neighborhood, you know, no one can get in county Medicaid transportation pretty much.
Programs, sorry. Are those flag programs moving to what's called like ride on demand, where you can call and let them know, rather than standing on the corner flagging and then waiting 20 minutes, but 3 hours a day before, say tomorrow at 10?
There's eligibility requirements for that too. So they do have a system where you can make appointments, but there's requirements for it. So everyone couldn't do it, but maybe a dialysis person could do it, but it's still, you know, they have this time frame. Yeah. And so you could be standing out there for, you know, 20 minutes longer because you don't know how many stops it's going to be because it's a flag system. So where yesterday there was maybe no one standing in the route on your house to wait toward your house, the next day and maybe 6 people standing out on route toward your house.
There are, as everything, there's technology solutions, there's process part of that, and then there's the third leg, which is the people. So how do you train? How do you manage what workflow, you know, is required? But it's always those. We met with the transportation. We're hoping they can get an app system because I feel like that would be better for the residents, because if you could see that your bus is within 1 mile of radius, then you can prepare to start going to the bus stop then, as opposed to this long time span being and waiting out there. It could be cold, it could be hot, it could be rainy. But if you had some type of app, at least you can say, here comes the bus. It's 1 mile from your road. Those apps exist.
They exist.
They exist. They're in the market.
Yes. And so, you know, they said they are applying for grants to get those out. I think that would be one way to solve our issue. But right now, of course, we don't have that. So.
Right. Agreed.
Go ahead.
So the technology piece works great as long as you have the technology.
Mike, a little closer, yeah, the people online won't be able to hear you.
So the technology piece works great as long as you have the technology. We get information and surveys all from people, and like I call this the low-hanging fruit. We always ask the same people the same questions and we always get the same answers. The issue becomes for a number of the people that I don't serve but need to figure out how to serve, they don't have access. Part of some of the solution that perhaps the state can support is community and neighborhood level access points where people can schedule. They can go to a convenience store or a liquor store or a library or a town hall but it has to be places where people. So government buildings are not the only places where I need it in liquor stores and grocery stores and convenience stores where people who have no voice, who have a fear of government, who will not go into a government building, but they will go in and access a trusted provider of information, and that becomes the places where they shop and where they populate. It can't just be where I would go.
Thank you for that perspective. And we're going to kind of shift because there is a lot of discussion and comment to that thought of what if we had a statewide coordinated effort where everyone in the state of Maryland can access one number. And we talked about 211, the pros and cons of that, the challenges that folks will face if they're not able to even have technology to access 201, or what if transportation can't get to them because of their terrain. And so now we're going to shift, and what they're trying to do is come up with a statement that can be presented to the state to see what could be a statement that encompasses all of the challenges and unique patient demographics that we have in Maryland so that each county and local constituency can try to implement things that will work for their people. And so as you can see here, we've developed a proposed policy statement. This has come from all of the information that you guys have provided in the roundtable meetings, as well as staff at the state level. And you can see it there. Reestablish the State Coordinating Committee for Human Services Transportation to provide guidance to regional coordinating bodies, MPOs, which are the Metropolitan Planning Organizations, and program funding. Maryland 211 is the conduit that's suggested for that. Now, we've heard, again, what 211 can do, how 211 is not effective for data collection, maybe even for folks who don't have access to telecommunication that is best suited for the different ways that they can reach 211, whether it be an app or a phone call. And so looking at this, we have that state entity there, the State Coordinating Committee, but you all have already mentioned that, for example, Garrett County, that is an area that is not going to match what Annapolis looks like, and Arundel County. And so what might work for most of the areas in Maryland might not work for a few, and that leaves them out. And so I heard someone else say that there could be local organizations that serve as a hub or as an aid to helping folks who don't feel even comfortable talking to government or picking up a phone to call 211 at all. And so one of the things that we were hoping that we could do with everyone here is look at this statement and suggest terminology, language that could make this more inclusive and that would be better in addressing all of the unique challenges that Marylanders face when it comes to transportation and their medical needs. And so now we would like contributions. And before that, I just wanted Yolanda to add a bit.
Okay, regarding the, reestablish the State Coordinating Committee for Human Services Transportation, there was a committee, or there is a committee that has been meeting already at the state level, and you can find that I think that information was forwarded to everybody in the summary sheets. What we may want to do is revamp that committee, maybe see, maybe it needs new membership and things like that. And of course, I don't have all the answers. That's why we're here. Also, the 911, the 211 inventory. I also made notes that there was an article on October 3rd of this year, 22, that says new program helps emergency rooms connect community members to community resources. So there is more opportunity to expand 211 to better serve us. But I think this is the conversation we need to have with them.
Yeah, I really think that we're on to something here, and then it's about defining what the mandate of this body might be and how best to serve the citizens of Maryland. So understanding there are different regional components, so we can't have it purely centralized out of Baltimore, but without representation. So how do you build an infrastructure which says we have mandate to serve rural communities? We also want to understand, because there are silos, there are very difficult silos to break down with existing transit. MTA, my company does the technology for it. The former MTA chair is now involved in our organization. It's a very hard silo to break down. So how do you break that down? How do you reach out to them to say, instead of a flag program, we want to be able to create a ride on demand so someone can book and yet have the opportunity to verify eligibility? How do we cross the barrier between including veterans and IDD populations and Medicaid and seniors, and all of these have their own rules, their own funding. So the system that underlies and the technology that underlies needs to be able to understand, I may access a service based on different funding models than everyone on the table. So how do we do that? And then how do we staff it? What does that mandate look like? So that each one of our communities and counties understands. And you make an interesting point, that people side, how, 211 may be good for some, but there's got to be other entry points into the system. And guess what would have happened to the 211 system during COVID? It would have been completely overwhelmed with other calls. You can't have that as the only conduit into transportation because it will get swamped. So how do you build that statewide organization which really moderates the existence of silos, that picks the best pieces of technology, flip it around, understanding the different communities and how do we each serve them? It's a tall order, but it requires, some really good, the beginnings of really good understanding what the needs are, which is what this is about.
And we have one hand raised online from Delegate Robin Lewis's office. If you can unmute and speak now, that'd be great.
Thank you. So I am so grateful for this convening, for the conversation, for all of the heartfelt ideas and recommendations. Just let me say what you guys are doing is actually really important, and I appreciate it. As I listen, it occurs to me that the suggestion to reconstitute the statewide coordination committee is maybe one of the strongest recommendations that you can press for. And I'll just tell you why. We are about to embark on a new administration. There will be a new governor starting in January, and that new governor will be making appointments to commissions, to committees. I checked the website for the Statewide Coordination Committee on Transportation. The last annual report that body produced was 2016. The chairmanship of that group is currently vacant because the current governor has not appointed anyone, or no one has accepted an appointment to run it. And it really is in the hands of the governor to make those appointments and demand that the organization, that this committee, function and deliver. You are now in a really strong position to advocate to the incoming governor, to demand that this coordination committee be reconstituted. And as a group, you can even put forward recommendations for who you would want to sit on that group. A lot of the challenges that you guys have described, the lack of information, the lack of coordination, obviously, could be solved by a group like this. And it already exists. It just has to be, we need a governor to demand that the group function and to put the people in place. So I hope that you will take this opportunity and use it. The timing is perfect, and you've done so much of the work, the thinking and the brainstorming. The timing is perfect for you to use your voices and demand that. The last thing I wanted to say was the representative from Calvert County who talked about the flagging bus, the bus system that's runs by flagging or whatever. A question that occurred to me is, what is the demand for the transportation service? For example, can your jurisdiction deliver data on how many people need dialysis transportation services? And I'll tell you why I ask that. It helps if you can be very specific about unmet need and what it would cost. If you can come up with a number like that, there are 100 residents who need, 20 dialysis trips per week. Each trip costs $100. That's $2,000 we need every week. If you can deliver that level of detailed information to an elected official like myself, you give us more ability to demand the resources that you need. I just have to say this last thing, and I'll turn off my mic. I'm the only elected official in this room. I don't represent any of the rural counties. I don't know how strong your lines of communication are with your state delegates and state senators in the rural counties that are represented in the room today. I'm sure you are, but I just want to, highlight that I am absolutely committed to supporting your needs. I sit on Health and Government Ops Committee, so I set health policy, and I'm also a transportation policy expert in the House who's always looking to break down the barriers between conversations about health and transportation because they're connected. And so I hope that you'll see that as an opportunity to really get some attention to your issues, because I'm here. All right. And I've been here since the first meeting. So thank you.
Thank you, Delegate Lewis. I'd like to just say that I've never put eyeballs on the numbers themselves, but I have been told by, by Charles County's Transit Division that over 50% of their paratransit budget goes to serve dialysis patients. I mean, it is a huge number that we have, and these patients have to go there 3 times a week, 4 hours a time. Their employment rate is about 18%, which means the unemployment rate is the opposite, which means they probably don't have a car, they may not have health insurance, and they're in a bad spot.
So 50%, you say, of the transportation budget is for dialysis alone?
Over 50%.
And where was that again, Yolanda?
Charles County.
Wow, thank you.
We have 2 questions in the room, or 2 comments in the room, and then I want to read these online really quickly. M. Simmons 1 says that Pennsylvania went to one scheduling software, EcoLane, for all 76 counties. This helps with transportation coordination. Again, that software is called EcoLane, ECOLANE. And then from S. Danishpur, hello, to anyone having issues with getting Medicaid non-emergency medical transportation services for participants receiving dialysis, if you could please follow up with me. My name is Sarah Danishpur, and we'll provide the email address and provide additional details as we have provided accommodations for participants in the past. So those are some comments to take note of. And I'm going to have this gentleman, another gentleman here.
I think there's a lot of commonality between us, even though there are differences. In Anne Arundel County, we have a large rural section to the south. That's our South County folks. And we started an on-demand service there called a Call and Ride. We're hoping that we can upgrade and add an app component to that, but we're not eliminating the Call and Ride. People still need to call and ride. Some folks aren't comfortable with cell phones. They're not comfortable with the internet. So the app will help those who want to use the app order the trip, and it will also help our dispatchers coordinate the trip through the app at our base operations location. So another key piece that our friends in Garrett County brought up is that network of places and connections. Where can you build out kiosk and education centers and have regular trainings, senior centers, libraries? You can have kiosk at grocery stores. Where are the places where these people are going? Medical buildings, facilities. That's how you're going to be able to connect with this population, because they want to connect, especially now that we're coming out of the pandemic. They want to connect and they want to learn, and they're ready to absorb. They don't want to be exiled from the common population.
Thank you. I think it's Bill.
Yeah, Bill Murphy, Friends of Disabled Veterans in Carroll County. Responding to Delegate Lewis's comments, I think one of the most important things as far as this committee is concerned is not to have all of it in one location, like in Baltimore City, Annapolis, or whatever. To have the people that are represented, I think we all heard the same comments from that fellow out in Allegheny County and different counties.
it's very specific needs that you have in each one of these counties, okay, is not going to be addressed when you have a large committee and it's not with the local representation of the local people that are in that area, because they know the county best. And I think if we go from there, the administration on this 211 system, it should be ideally located in each one of the counties that we're talking about. And right now, I'm working on a venue with the court system in the state of Maryland. And we're working on 8 specific counties in Maryland to have a veterans treatment court. And what we're doing there is each one of the individual counties, they want to have control and not have all the control in one entity like down here in Annapolis or wherever it might be. So you get your individual state's attorney that knows best how to deal with our veterans that are facing misdemeanor charges in that specific county. And we're reaching very, very high success rates throughout the 8 counties that we're working on. Thank you.
Thank you.
A couple of thoughts. I completely agree. Again, I see definite need in order to coordinate at all 3 levels here, state, regional, and local. And I think Maryland set up so beautifully for that. We often work in these ways at the jurisdictional level. As Delegate Lewis was speaking, this rings very familiar on a commission that was formed this past 22 legislative session around healthcare workforce shortages crisis. And I think there's certainly room for us to build a policy statement around establishment of a commission or stakeholder work group to do some of this exploratory. I think we've had just 3 meetings here and we've again and again discussed the need and the gaps. But what we don't have is some of that hard evidence data. We don't have the inventory of systems. And so to me, it seems like a stakeholder work group that brings together prescribed membership, but also follows Open Meeting Act of Maryland, brings in public comment, could have those areas of exploration, spend time. A lot of these go about 1.5 years. They're enacted around July. They'll have an interim report in December and then a final report the following December that then has recommendations that come along with it. And I think that's the kind of things that we can do at the state and setting up a regional, building in the tailoring that we always need at the local level within the state. So I'm seeing that as that state level, increase fiscal and supportive resources such as that state level work group or commission.
Thank you.
I'd just like to add that I think to build on that, it should be, where possible, invite technology vendors so that as you're having that discussion around need and difference, people can share the art of the possible. So I'm just looking, I ran my customer list for the state of Maryland. We have 43 organizations between myself and my sister companies work with, from WMATA to MTA to Annapolis Transit to Frederick County to all over the place. So, I'm here and this is really the first time that I'm trying to get my arms around and join you at the table, and literally putting my affiliation aside, but really just talking about process and how all technology providers really can input and shape what is the art of the possible.
Thank you. We have 2, I think 1, 2, 3, and 1 person online who's been waiting patiently. I think that's Noel.
Yes.
Flower. Thank you.
Yeah, can you hear me?
Yes.
Okay, so I wanted to support the statement about reforming the committee. That was my first thing I wanted to say. And then in terms of the demand, the delegate had mentioned if we could get data on demand for public transport. It is a catch-22 kind of situation, because if you don't have good public transport, it's really hard to gauge the demand because people can't access it. What we do know is if we provide transportation to people to their doctor's appointments, we save money, and we have demonstrated that through the Wheels to Wellness program. So I just kind of want to put that out there. And then with the apps, I love the idea of rideshare apps, but in rural, there's a couple things. First of all, you need to have a funding source for people who are not Medicaid and who are low income. And then you also have to have people who can provide the ride sharing services. So for example, in my county, we have no real Lyft or Uber access, but if we could create the demand, then maybe we could get access. So it's sort of similar to the public transportation. We just don't have the access. So, thank you.
Thank you, Noel. Okay, we have this gentleman right here, this woman, and then another woman here in the room. So I want to go in that order, and then we're going to do a time check because it'll be our lunchtime. So 1, 2, and 3.
Thank you. Scott Warner, again, with the Midshore Regional Council. I was going to speak right before the delegate, and I'm so glad I didn't. And I'm glad she looked it up online. I actually did serve on the state coordinating committee. When we lost our, through death, the gentleman that ran our Maryland Upper Shore Transit program, so I stepped in. That committee's still around. It hasn't met for a couple years. And there is a plan since 2016, whether it hit online or not. The last thing they did is when I was on it for only like 2 years of attending the meetings, you'd be shocked how small that group is. I was. It's less than 2 of these tables. So I was shocked when I went to the meetings thinking it was big because we knew somebody had been going for years. But what a lot of you apparently don't know is the regional areas, and we do needs assessments because we work with MTA through KFH Group, who's subcontracted. The last thing that state coordinating body did is re-engaged, which hadn't been done for like 10 years or 12 years. They re-engaged KFH Group. The state paid KFH Group, talked to the committee, but then really took all those plans that are updated every 3 to 4 years, made them into one big plan. So the plan was there. And to be quite frank, the Midshore Regional Council brought and had them reach out to the governor's office because the governor's office prior had never been engaged with. The governor's office was waiting for the next meeting, and MTA never made the meeting. Now, I agree with the delegate, that's also the governor's fault. So, because they didn't engage that power on there. And we do have an opportunity to kind of move that. And I think that a lot of things that everybody wants to do here is what I'm hearing. Some of it's actually in place. We have to revamp it and refresh it. But it's not like, okay, we got to wait for a long time. There are some pieces there, and re-engaging that committee and making that committee much more broad and making MTA, where we used to go to Hanover and schlep down to Hanover, and go sit in a little tiny conference room that's a third of the size and make them hear a whole lot of other people, it would be a big difference. And as far as the delegate's concerned, I happen to be on the executive committee of the Rural Maryland Council. So if there's anything I can do to help the delegate, Charlotte, you know that you can get hold of me any day, any hour. So I'll be more than happy to, whatever the delegate needs or whatever the RMC needs to move that forward in that communication. I'm at least willing to at least tell you what I know and the people that were actually running it. And I don't know if they're still standing up or not at MTA, but at least who was involved.
Thank you, Scott. All right, ma'am, did you want to speak next too? I saw you raise your hand. You're fine. Okay.
Hi. Oopsie. Hi, once again. Delegate Robin Lewis, thank you. You addressed something and I don't know the woman across the hall here. She had spoken of the fact that, yeah, we need an entire state and / individual county listing, because of rural differences. But the other thing is too, in order to expand this coordination, 2 things. One, we all talk about technology. Not everybody has a cell phone, and not everybody is online. Fortunately, with my particular organization, FDVCC, these people call us direct. Heck, I've even had people walk up to me on the sidewalk, and I'm not joking. But in order to gather people across the estate, regardless of race, creed, color, I say accessibility. We have people that are handicapped. We have people sitting in dialysis I'm sorry, yeah, that is a 4-hour endeavor, and actually, I'd like to tell you, it's more like 6. And I know that from experience. But the problem here lies in that a flag system, you wait possibly a half an hour. I had a person tell me that they used a county ride. They waited 3 hours to get away from their appointment. Now, let alone their appointment aside, that was the trip to get to it, had to wait to get to their ride, they get dropped off, they have their appointment, then they had to wait an additional 3 hours before somebody came and picked them up. That's not funny. That's horrible. I mean, here's my motto. Nobody chooses to get sick. Nobody chooses to be in pain. And it's our responsibility, and obviously everyone in this room has a commitment for that across the state to help these people. Yes, we're pretty much veteran. I say pretty much every day my boss tells me something new. But all that aside, we try to help as many people as we can. And, it's not just technology, because not everybody has it, but that education to get out there, as I mentioned before, I dropped my cards off at several places, and I've had a person turn around and said, I've never heard of you before. And I'm like, you're joking, right? And they're not. The education, 211 could really be an advantage across the state, across all the rural areas, be it the city, be it good old Carroll County, that's my spot, be it small spots, like I mentioned, Pocomoke City, something tiny, Salisbury, which is not so tiny, and then going all the way out to Garrett County. They don't all have that education to all the resources that are available. And that is very, very important, because some of them, it's eligibility. In my case, we do mostly veterans, but cost. Some of these people, low income or their accessibility, they're handicapped. I'm sorry, when's the last time you wanted to put your mother sitting out on a sidewalk waiting for a bus that hopefully has the accessibility to put her on it? It's not funny. That's pathetic. And we need to do better. And I think we all can do better, and we will do better. Delegate Robin Lewis, thank you. As far as your term, the Demand Coordination Committee, I might be a little bit ignorant there. I didn't know. I caught you and I was writing. But we need to take that on and give it the coordination it so well deserves for everybody across the city, across the counties, and across the state. Thank you.
Thank you. And what a wonderful comment to wrap us up for this first segment. I think Noel's hand is still raised from earlier, but if not, just give me a moment. It is after 11:30, and this is the time where we were supposed to do lunch, and while we're eating lunch, watch a movie or vignette. So do you have instructions for lunch, Yolanda?
Hello, everyone. So lunches are just right outside the store on the table. There's several selections. There's bottled water. If you'd like a different type of beverage, there are some machines right next door. And please return at noon online.
Before you go online, do you guys want them to watch the vignette during lunch? Because it says lunch and vignette, but I just wanted to let the people online know that there would be something playing if they left or not.
We'll probably put it right before we come back in full session, so give everyone a chance. And we said, 12 o'clock? Yes. Okay, 12 o'clock for a movie.
Okay, so we'll start the movie at 12 o'clock, and then we'll go into focus area 2. So enjoy your lunch, everyone. Okay, so again, we hope you enjoyed this delicious assortment of lunch that we have for you. We are now going to turn it over to our vignette before we start to jump back into our discussion.
Delmarva Community Transit provides transportation to 4 counties on the Eastern Shore where the poverty rate averages 12% and the population is over 65 averages is 24%. As with all rural transportation providers, countless citizens rely solely on Delmarva Community Transit to get them to their medical appointments. We transport riders to medical appointments that are up to 50 miles from their home, for example. As operating costs increase, we continue to have to look for funding from grants other than the 5310 grant to cover transportation. Other agencies such as United Way, social services, local health departments, and now even local physicians are purchasing bus passes for medical appointments. There's opportunities for improvements, which would include, in my opinion, increasing in funding for senior rides. With the current economy, there's an increasing burden on our citizens, and potentially it may be harder to receive additional grants. The reinstatement of a state coordinating committee. This committee could focus on different regions of the state instead of one plan that fits all. We need to improve communications with local healthcare providers to determine ways to improve on it, make an appointment, scheduling. We need to establish an NEMT program that could address issues affecting all citizens, especially the aging population and ones at or below the poverty rate. DCT provides fixed routes, deviated routes, and door-to-door medical. One stops for veterans and persons with disabilities that cannot ride public transit for medical appointments. And we also offer travel trainers for new riders. Delmarva Community Transit has seen a huge rise in medical appointments for dialysis appointments, methadone treatments, and cancer treatment appointments, just to name a few.
All right. And so, as we just heard, some of the same, basically all of the things that he mentioned are things that you all have touched on, if not today, in prior sessions. And so that definitely rings true as we think about the last focus area, and we definitely are going to make sure we capture everything. As you know, this meeting is being recorded, so we are going to review the video later and make sure that we have everything captured and are able to really put things in the categories that they belong to so that we can really have some solid recommendations. And so now, as you're finishing your lunch, we're going to go ahead and jump right into focus area 2. And in this area, we're looking at the industry characteristics. And so since socioeconomic status is connected to health, and since demand exceeds services provided by social welfare, transit, and healthcare, characteristics for each industry should be evaluated. And so we had some solutions that we came up with, and I'm going to let Yolanda go through the bullets, and she can elaborate on them as she wants to, and then we're going to go into the same thing that we did last time, get contribution, comments, and questions from you all.
Thank you, Leslie. In front of you right now, you see the issues that we identified from the last meeting, some of the characteristics. We heard earlier TNC companies. These are transportation network company like the Ubers and things like that, and Lyft. Companies could be expanded, and this, as pointed out earlier, this is a challenge in the rural areas. We heard comments about that in focus area number 1. Second issue that was identified is that the mobility technology could be integrated statewide and regionally. It was pointed out there are some literacy problems, internet access, and trust issues, and I think we heard that in focus area 1 as well. The third issue that was identified was public transportation that was challenged by electric vehicle conversion and the electric grid. That was definitely from something that we heard from the transit organizations, that the vehicles will be difficult to convert to electric, but also the impact it's going to have on the grid itself. There was a lot of discussion on the fact that there's a lot of shortages statewide for drivers as well as community health workers. And finally, the Medicaid forms are challenging to complete. So basically, these were some of the possible solutions that we heard. Is number 1, regional partnerships could be made with TNCs, nonprofits, for dialysis community members. And the idea is that we know that dialysis patients have to go to visit their centers at least 3 times a week, for 4 hours. That provides a basis for a reliable source of income for the Lyft operators and the Uber operators. That could be something that could be expanded upon. Second thing is stabilize the transportation funding. We heard several comments about how there was a decrease in transit funding because of the CARES Act. I think was one point. Yep. And then finally, I wanted to point out Federal Register number volume 87, number 172, pages 54, 71, and let me. This is entitled. This was out for comment. The comment period, I think, ended on September 7th, 2022. But this section is called Streamlining the Medicaid Children's Health Insurance Program and Basic Health Program Application, Eligibility Determination, Enrollment, and Renewal Processes. Given that title, it was kind of long, so you can refer to that. But it was in the packet that was sent out. That would be something that we would probably want to monitor, and we can maybe implement some of those updates to make our process a little bit smoother.
Thank you, Yolanda. And so with that, we did want to open the floor once again for those of you who, one, might have questions, two, may have possible solutions to add to this list, or maybe you want to add on to some of the bullets that are already represented there. And then, of course, if there are any concerns or challenges that folks should be considering and thinking about that you're aware of as we face looking at possible solutions, we want to hear from you all. So any hands raised, whether online or in the room, we can start in either form, the virtual space or the in. Go ahead.
So with respect to TNCs, Uber and Lyft, particularly in rural communities, you're driving long distances. Is there a source that would cover the cost for those individuals? Because my experience is a number of individuals who live in rural communities have lower incomes. Part two of that is not, if to my knowledge, I'm not sure that Uber or Lyft offers any accessible transportation for someone who uses a wheelchair. So how would they accommodate that? And to a certain degree, I know with older adults, there is a certain level of concern because Uber and Lyft are new concepts. And so they're fearful of use just based on some of the stories out in the community. And then fourth, technology is great, but particularly among older adults, if you don't know how to use it, that certainly would be problematic, so.
Yeah, so I know that Lyft, when we met with them, Courtney and I, they're building a Lyft Assist program because, again, the need is there, right?
Mm-hmm.
They don't walk people to their door. They don't have the capability of handling the wheelchair and the walkers and so forth. So they are working on that.
So what's the timeline on that?
I couldn't tell you. I don't work for Lyft, so but
No. And I ask that because I've heard that on numerous occasions.
Yeah.
And you splinter a significant portion of the population when you can't provide that accessible transportation. So
yeah, I know from a health plan, I can honestly tell you, we face it, right? Because the majority of our people need help, right? With that being said, when we did meet with them, the biggest strategy that we're using now is we're pulling everything together to give them a business case to say, you've got a $10 million opportunity here in rural Maryland, you know, versus me coming at them and Courtney coming at them and, you know, the college coming at them. So part of, and maybe you could speak a little bit more to the survey and stuff that was done, but I know Mitchell has some stuff that he wants to share as well.
I think when we talk about the Ubers and Lyfts, they become one part of the transportation solution versus the only solution. But I do think that private ride-sharing model in rural communities is important to contribute to that continuum of transportation services. And then it becomes more of a model or a program or an approach where when someone calls in or utilizes an app to schedule transportation on the back end, whether that's a person assisted with technology or the technology assisting the person that's making that call, then appropriately slots that individual into what's going to work with them, what are their needs, who's the funding source, and then that technology on the back end with the capabilities able to then provide the billing piece that we all need based on our various funding sources. But in terms of timeframes, we don't have. But what we've done in Western Maryland, because we've been looking at how to build that transportation infrastructure, and we're looking multimodal as well, we have done a survey with our community to look at what the transportation needs are, whether public transit is actually meeting those needs. If it's not, what are the challenges? How many people in our community have utilized a ride-sharing service, which was really significant. Allegheny County had over 50% that responded to the survey that have used a ride-sharing service, but only about 5% in Allegheny County because we have one or two drivers. And obviously, when you have one or two drivers, it's not cost efficient, it's not convenient, it's really no different than any other means of public transit because it's not on demand, and oftentimes that's what's needed. But there does seem to be an interest in utilizing it. We did the whole population, and again, we're looking at this from, yes, we need health and human service transportation, but we're also approaching it from the standpoint that we also need transportation for employment, recreation, and to support tourism. And if we can build a robust transportation infrastructure that meets everyone's needs, then it's not going to be always looked at as really transportation of last resort, which we have really struggled to gain a lot of traction around.
Is it on?
Yes.
We have used, or tried to use Uber and Lyft with Wheels to Wellness. The main problems we ran into was that the drivers, it was a second income for them. They like to work on Wednesday night, Thursday night, Friday night, Saturday night, mainly servicing those people who had consumed alcohol. And our job is to carry people to the hospitals and doctor's appointments in the daytime when the service levels were very, very low and spotty. In addition to that, some of our veterans who needed transportation to DC, they wanted, it was a reimbursement to them. And one of our veterans was quoted to make it to a procedure in DC, the round trip, including about 3 hours of wait time up there, would be about $550. And, you know, they can't, a lot of people don't have a credit card to put $550 on. So there are challenges using them. They could be useful. I know in the urban areas, when we were working with our previous software provider, they were getting rides all the time. When we tried to use their software in the rural areas, it failed miserably because they had 11 providers in their core area where they had tested the software, and we only had one provider for transportation in the rural areas where we were trying to implement something. So I like the idea, but I think it has it's a one piece, as you mentioned. It's not the whole solution.
You know, very well said, and it really just, the reason is the drivers are not Uber or TNC employees. This is occasional contracting work, and okay, an occasional driver, second income, great illustration. I need to plan my business, I need to plan healthcare delivery. Can I do that reliably? The answer is probably not. The other opportunity, and correct, there's a blend, but there's one component which is maybe mileage reimbursement. Maybe you're husband or wife, kid, child, friend, neighbor, someone in your community can give you that trip in their own car, not an Uber car, but their own car. It's the same thing. If we can fund them in a way that the state or their funder allows. So we do that quite often for Red Cross, for Cancer Society, for Easter Seals, for a few others, and it works beautifully. So it really is about having a whole bunch of levers in a community that you can pull to make sure that it's appropriate and reliable.
I'd just like to say that in our organization, like I say, we, in Friends of Disabled Veterans, we've been in operation now for 6 years. One of the biggest challenges that we faced is insurance. And you're talking about Uber and a lot of these others. For example, I worked personally about 3 months to find the insurance company that could basically give us $1 million coverage and take care of us. The other issue is, like I said, John said over here about the drivers, and a lot of the drivers, they're not really prepared. What we do in our organization, we have a fellow that's a gentleman that's Larry Appel, and he's a EMT for over 40 years. So he gives us classes and makes sure that we can operate with our ADTs and CPR training, and everybody's knowledgeable about how to do this. But it takes you just don't go into this. You need to have trained people to doing it. And one of the challenges that every business has today is getting qualified people that can turn around and do the job for you. So I'm very pleased that we have Nancy and people like Nancy that are very, very familiar with our operation, and we could go out there and take it. But it's, it's a great challenge, even for a company like Uber, because a lot of times people are looking at the money instead of looking at the service they can provide. And what we do is, Nancy, and including myself, we don't take any money from the organization. We're all volunteers. And we have a commitment, in our case, to veterans throughout our area that we're at. And I had the opportunity to go out to Frederick County and make a presentation on how they could build a private nonprofit non-emergency medical and dental transportation for veterans out in Frederick County. They have like 20,000 veterans that are out in Frederick County. We have in Carroll County, we have 10. So this need is throughout all the people here from all the different counties. There's a great amount of veterans that are out there, and all they're looking for is opportunity to take care of fellow veterans, and this is what we're doing. And I think coming together like we are here today, we hear the outstanding comments of everyone in here, and this will be able to take this back to Annapolis here and say, hey, where do we go in the next step? The one thing I think we have to really caution about, and I've looked at this for a long time, I've been doing this for a long time, is we don't have duplicating types of operations in the same county that you're in, because it's just a wasting money. If you don't, one of the first things that we did is we analyzed that when we've organized our organization, what our business plan was, who we're going to affect, and what type of data that we need. As Delegate Lewis presented before, because if you don't have the data, a lot of times, the government, they're going to say, hey, we're not going to support this because they don't have the data or information that they really need to give you that grant that you need. So you need to really research it very, very well and make sure that, what you're doing is fulfilling the needs that are out there in your respective communities. Thank you.
Thank you. And you have another comment in the room, but just one of the things that is apparent throughout is that this is not an easy problem to solve, and it's going to take everyone in this, in this sandbox, so to speak, to really pull up their sleeves and figure out, what can I do to push this forward? And one of the things that we're hoping to accomplish is to have that baseline understanding of where are we trying to get to, and have decision-making points identified so that folks are able to make sure they have the right players at the table and that they have the community involved as well. And so I really like the idea of having funding models that allow community members who could possibly give transportation so that if there's no Lyft, if there's no Uber, there is no public transit that runs routinely, people can still have another access to get somewhere. And so,
one area that I think you brought up that we talked about quite a bit at the first round table that we didn't hit on this list solution-wise was workforce. We talked about that quite a bit, so I think solutions around workforce development will be really important at each of these levels we discussed as well.
go ahead, Nancy.
I got a name now?
You got a name. I told you guys. I know your
popular.
name when
Thank
you
you.
call and if you say it out.
Hello, everyone, again. Oh, what was my brain? I thought, okay, I just had a brain cramp. As far as addressing some of the driving eligibility issues, need to kind of touch base with the fact that they're going to a medical visit and they're very ill in some cases. Sometimes it requires them to have a healthcare provider and or a spouse or, you know, a family member with them. So when addressing this issue, it's not just that client. I call them clients, by the way, just to respect the fact that they are veterans and they're going to medical visits. So by all means, it needs that respect. When we're transporting them and either, I mean, I have had a day where I did, oh, what did I do, 4 that day? Huh? I had over a little, yep, I did 4. It was a really fun day. But with that in mind, you're sometimes taking more than just one person, and you've got to address that ability. When I say, you know, you got a wheelchair, and then you got somebody else that is able to be, you know, that can ambulate. You know, that's a big piece. And a lot of what we do is we have, you know, like Bill had mentioned before, we have clients that have had, you know, Agent Orange affects veterans. My personal favorite, honestly, is the PTSD. That's across the board. And you don't know when that person gets in that vehicle what is going to affect them. And you really have to be sensitive. I've learned a lot. My brother works with Fort Belvoir. No, what's the one in D.C.? At any rate, he works with a couple veterans administrations, and he does teaches water rescue and takes some of the veterans out of the hospitals and takes them out on the water to put them in nature. It's an interesting program he runs with. And he and I found out one day, just tripping on a conversation, talking about veterans and dealing with PTSD. You talk about training. I'm sorry, an Uber provider is not going to know when that veteran gets in that car, or in my case, veteran, gets in that car and some of the challenges, whether they be physiological or whether they be of a mental capacity. And it's, you know, it's not their fault. Like I said, no one chooses to get sick. No one chooses to be in pain. But they all need to have some help. And so with respect on all that, that has so much to go into this whole community, I forget what Delegate Lewis had mentioned, the coordination committee. There's so much that needs some attention, and I'm sad to hear that you said this is the last table.
For now.
Yeah, for now. Hello.
For now. It won't be the last meeting
We're
for
coming
sure
back
on this topic, but
Sorry, I mean, like, wow, this kind of opened a huge door for us. And us being a nonprofit, we're not, you know, I've heard, and somebody had mentioned about somebody getting transported, waiting 3 hours. That didn't blow my mind because I've heard of it before. But the other thing, I transported a woman, and then she was very, very gracious to give us a donation. And I sat back. I'll tell you right now, I have experience. I worked with Care First Blue Cross Blue Shield for over 25 years. And I can tell you right now, that wheelchair transport is not covered, A. B, guess what the going rate is? Anybody got an idea what just an hour is? It's over $300. okay? And there are people out there, as sad as it seems, that are scooping up on it. Oh, we can do this for the money. It's disgusting. You know, they should be able to have access to transport just because they're in a wheelchair? Oh, no. And I think that is absolutely appalling. And a state should be, you know, if you're handicapped, you still need help. And there is no reason that they should be pushed aside because of a health issue and pretty much ignored or having to pay absorbent fees. I just sat there and chuckled when this woman gave a donation. It was very generous. And I handed a check over to Bill, and I was like, you have any idea how much that transport would have cost? And it was, I added it up in my head, and I know from somebody who used to run a personal ambulance service, that particular transport, without going into the private information, was probably a little bit shy of $600. That's sickening, you know, and I hope this group can come together and make this something really, really awesome, and I know we will, so that's just my thought.
Definitely agree, and just don't want to get the have you all forget about workforce was mentioned in the area, not just of the medical training that one needs to really be able to assist someone adequately with the sensitivity that is necessary for that situation, but also with cars moving to electric, there's a whole nother training that has to happen for drivers, especially not just drivers, but those fleet units and facilities who have to coordinate and maintain these vehicles.
So I think we've collectively said, and I think most people around the table would agree, that it takes a village. So it's not a one-stop shop. It's not just public transit. It's not just nonprofits. It's not just Uber and Lyft, but it's a combination and a family of services. And so it's not going to be one size fit all, because each of the counties and districts are unique in their own right. So it's understanding what the needs are and then the resources that we can tap into. My agency is a nonprofit, and we get 5310 funds. We also get funds through foundations. We're operating in 5 counties. We consider all of our members, whether you're using the services or providing services, you're a member. But we rely heavily on volunteers. And I gotta say, we have some of the best volunteers. We have people who will take 2 rides in a day. They don't want mileage reimbursement, and they don't want to use that as a tax write-off, you know, and so we work very closely with them. With our primary audience are older adults, and so in cases for us sometimes, pre-COVID, a driver would go into the lobby with the individual, sit and wait, stay outside in the car. We offer a friendly elbow, provide some additional assistance, things that some entities wouldn't do. But as we age, that's what people need. So I think we need to make sure that we stay focused on the whole collective process, and each entity has its important role. And if we can pull all of those resources together and develop the appropriate technology, then the people in the communities are the ones who are going to be served best.
Absolutely, well said. Anyone else online or in the room want to add comments, contributions, have a question, or anything that you want us to think about as we think about possible solutions? All right, well, we'll go to our next slide. I don't see any hands raised. We'll go to our next slide, and again, we're going to do this for each focus area. But as we think about a proposed policy statement, these are the areas that we want to make sure we include. And so I'm going to turn it to Yolanda to explain and elaborate each of these bullet points.
Thank you, Leslie. Okay, the first proposal policy statement is develop regional partnerships with TNC nonprofits for dialysis community members. This just kind of goes on to what I said earlier. We have dialysis patients that we know is going to be a reliable client for the Lyft, and it's actually Lyft Health that I know I've been in conversation with, and that could provide a basis. The second bullet is reinstate the MDOT funding that was reduced in FY21 due to CARES Act. As you know, the state received a lot of money from the feds in response to COVID. And my understanding is that some of the MDOT money was reduced down. We want to make sure that's reinstated. And also the final point is monitor Federal Register Volume 87, number 172, pages 5470, 60 to 54855. And that was the streamlining policies that they had just closed on the comment period for that. Thank you, Leslie.
Thank you, Yolanda. So with that, definitely want to hear your thoughts about what we've come up with as things that we want to make sure are touched and included in a statement. And also we have the space to add more here and to consider additional areas when it comes to this. And so anyone want to add to, or thank you, Bill.
I'd like to say, as far as a proposed policy statement, one of the things that would be interesting to come out of our meeting that we have here today is every year the Maryland General Assembly has a day for lobbying to go to the General Assembly and speak about the needs. And I think this is something that would be great for anyone in here to go, and especially with this committee that we're being formed. Because the one problem with having a committee is having it developed and having the information that are going out there so that the people in the general audience out here, the people, the voters of Maryland, would be able to know what is really going on and what needs that are out there. Because a lot of times, if you don't have that information, you don't get the money. And that would be my solution, would be to go on the lobbying day and go into the General Assemblies and speak for the people that have dialysis needs and all of the other medical needs that we have in our state of Maryland. Thank you.
Excellent point. We have someone online and I think 2 in the room, but that's legislative day, and organizations can choose what day they want to go to Annapolis and speak with legislation in reference to whatever your cause is. And specifically, we really want people to come out and raise this issue with our elected officials. So we're gonna have 1 person online and 2 in the room. It's A. Levine. I see your hand is raised. Did you want to?
Good afternoon. Yes, thank you. Good afternoon. I'm the health policy analyst for the Maryland Department of Health in the Medical Assistance, Transportation, and Durable Medical Equipment Program. I applaud all the efforts that are going on this roundtable, as well as the work that's been done in between meetings. I just wanted to address the policy point about monitoring the Federal Register, which thank you for putting the link in the chat as I was able to pull it up. The Federal Register policy that you have cited is specifically on the enrollment for Medicaid itself. Medicaid, non-emergency medical transportation is not a baseline benefit that is automatically provided to every Medicaid enrollee. So as you're watching that policy and as you're referring to Medicaid, I just feel compelled to make sure that everybody understands that there are separate requirements. The first of which is that somebody must have active Medicaid. So in order to obtain active Medicaid, this Federal Registry policy is very important to follow, as hopefully it will become more of a streamlined process. The second part, though, is that Medicaid transportation under 42 CFR 440.170 is the assurance of transportation, not the provision of transportation. So what that means is that in order to receive our federal funds, we need to make sure that that transportation is the transportation of last resort, that all other transportation options have been exhausted. And as we're watching policy, I just want to delineate the difference between other Medicaid services and the assurance of transportation to and from a covered Medicaid service. Thank you.
Can I ask if you can follow up with a description of what you were talking about, whether I understand you covered service, but I think it was, I know it's least costly, most appropriate, but if there's no other alternative, can you clarify what that means?
Sure. So if you look further into the COMAR 10.9.19, it will outline exactly what our program covers in the limitation section and in the scope. As far as available transportation options, if there's a vehicle in the household, if the person has a vehicle, if they are within 3/4 of a mile of a fixed route, meaning that then they would apply for paratransit, not flag down transportation, but actually apply for the paratransit, which would be a door-to-door transportation. So those options, as well as evaluating whether or not, and these next steps are not automatics, but evaluating whether or not there is a not-for-profit or there is a disease-specific organization that can help them, similar to the way the Leukemia and Lymphoma Society will provide eligible participants with transportation to and from chemotherapy. But as a safety net transportation mandated by the federal government to be the transportation of last resort, we are very interested in making sure that we partner with all of the already federally funded programs.
Right. So that's a really important distinction. So thank you for reviewing that for me and maybe the rest of us. But it speaks to the complexity of teasing out every single trip and what is appropriate and how to manage and maintain that. And I will submit that it's a very complex, onerous process. It took us like 4 years to build that part of our platform to do that. I say that simply because it is a very complex effort to tease out. And so, an IDD trip, well, how is that going to be funded? A senior trip, are they part of Medicaid? Or is it dual eligible? Do they have another local source of funding first? And how is it cascaded? I can get 10 rides here, then 3, then it goes to a different funding bucket.
So actually, if I can address that, because there's so many points of that I would like to be able to help with. I'm eager to be able to use our abilities. So within Maryland Medicaid, within the non-emergency medical transportation grants to the local jurisdictions, we are evaluating if a participant is eligible and qualified. If they are eligible and qualified, according to COMAR, they are reviewed and renewed every 90 days, or if there's a change in their clinical condition. The items that are maybe an issue of not being covered under Medicaid transportation would be items that are not Medicaid covered services. For example, if there is prior to the dental expansion that's coming up in January, many of the MCOs would offer dental coverage, but that wasn't necessarily a covered service. That was an add-on benefit that they were providing to their customers. That dental trip may not be covered because that's not a Medicaid covered service. That was an added service through their managed care organization. There is not a limit through Medicaid on the number of trips if somebody is eligible and qualified. I feel like there's so many confusions using the acronym NEMT that I really do want to make sure that we're separating out the Medicaid piece of it. Thank you.
I would love to have a conversation with you because as an MCO, this has been the biggest point of pain for us. There's a grant manager for each one of the counties, And there's different hours of operations for each one of the counties. And we've run into situations where if somebody needs to go to one county to the other, they're not being transported. They've been denied. Not only that, the prerequisites for scheduling, you may need a doctorate to get through in some cases. Additionally, you have to print out a form and you've got to get approval by the physician. And many of our members don't even have printers. I mean, many of us don't even have printers anymore, right? Let alone. So the way the system is set up, it makes it so difficult for anybody to access the service, that unfortunately our Medicaid population is not getting what they need. In other states, those funds are given to the MCOs in order to manage the benefit, right? In Maryland, I can appreciate wanting to give the local and the regional autonomy. However, it's now created a situation where now we can't access benefits as a result.
So I put my email address in the chat, and I would encourage everybody to go into the Zoom chat. And I know that my chief, Sarah Denishpour, has also put her email address into the chat. We would both be happy to receive comments and particularly share the statewide processes that are in place. Unfortunately, there are some variabilities, which if they're not brought to our attention, where there are strays or programs are straying from the policies that we do provide, without you bringing them to our attention, we don't know. There is a statewide policy for the times of operation on state business days, as well as those forms do not need to be downloaded by the participant, not for NEMT. The NEMT grantee will send those directly to the physician. There are forms, however, that it's sometimes confused with ours that are very onerous, which are generally for the paratransit programs, whether they're regionally run or whether they are on the Mobility Link in Baltimore, for example. I'm just using that as an example, is a 12-page form. Most of our intake takes place over the phone, and I would be very happy to walk through that process with you or any of the other MCOs. And the form is a one-page form for the physician. But please feel free to email me, and we will definitely make a time to sit down and go over that.
Thank you.
And this is Sarah, if I may just really quickly piggyback on what Andrea was saying. My division oversees the Medicaid NEMT program. I'm actually really glad that you say you want to reach out to us, because we are actively working on clarifying and updating our transportation policies. So we would be happy to chat with you. So as Andrea mentioned, please feel free to email me or her. Both of our emails are in the chat. And I believe the direct program supervisor of NEMT and DME is on the line too, so I can include his email as well. But thank you.
Thank you, Sarah. People are definitely putting their hands up and thanking the universe for that. So we thank you. And Delegate Robin Lewis, we see your hand is raised.
Yes, thank you. I wanted to make a suggestion about a lobby day idea. I think it's a great idea that the gentleman from, I think it was Carroll County, referred to this. It is really important for residents of the state of Maryland to know their elected officials at every level of government and talk to them, let them know what you care about, what you want. And I want to echo that suggestion that the folks who are most affected by the policy decisions that are made, one way or the other, really need to express their expectations, their dissatisfaction, their wishes to their elected officials. So a lobby day in Annapolis is a great idea. It's also really important for folks who are advocating on their behalf to talk to the elected official who actually represents you, that person that you can vote for. Now, mind you, I represent District 46. Only people who live in District 46 can vote for me. And I always want to hear from them, and they know how to find me. I'm very accessible. But the reality is I work for all of the people of Maryland. I vote on state policy. So I have a duty to every person who lives in the state, no matter what corner of the state they're in. And I care what you want, and I will do my best for everyone. However, and that's true for all of my colleagues, like that's just how it is. We work for everyone. However, to have a really deep and meaningful impact, I strongly recommend that if you organize a lobby day and that you bring people who are most affected by these decisions, whether they be folks seeking medical care, healthcare workers who can't get to work because transit is not serving them, whoever they are, be sure to schedule time with the members that they represent. Figure out who they are. You can come see me. I will welcome you. We'll hang out, but it's not going to be the most impactful as having someone from Carroll County go into the office of their Carroll County delegates and their Carroll County district delegates and their senator. Okay, please remember that. The last thing I will mention is that for nonprofits, the state agency folks, they know how to find us and we welcome you, of course, and we're partners. But for folks who are coming from nonprofit organizations, remember that your input is really important. One nonprofit organization has the potential to speak for hundreds, thousands of affected residents of the state. And so it's really important if there's legislation that's and policy decisions are being made that affect your work. It's really important that you either write letters of testimony for those bills, or if you can, appear in person to testify for or against those bills as well. But yeah, and wait, there's one more thing I forgot to mention earlier. We have a really vibrant General Assembly, a really vibrant state legislature. And there's so many of us who care about transportation and transit justice and access. There are so many of us, in fact, that we created a transit caucus. And a caucus just means a group of people who affiliate around some specific issue. There are over 60 members of the transit caucus, both delegates and senators. Over 60, that is almost half of the members of the General Assembly. That has never happened ever in the history of Maryland, that many people gave a hoot about transit in the state legislature. This is like revolutionary, right? This is really important. And the members of the Transit Caucus represent all parts of the state. There are certainly members from the central Maryland area, which is where most of the population of the state is and where most of the transit infrastructure is. But there are also members from Garrett County, from Charles County, and if I'm not mistaken, Garrett County, maybe Allegheny as well. So there is representation for the concerns that you have. There's a whole caucus devoted to moving transit accessibility and transit justice forward. So be sure to also identify those folks. I'll put in the chat a link to the Transit Caucus website, and you can see if your reps are there. If they're not there, you can encourage them to join, but really talk to the people who represent you, okay? And that's my last bit of advice. Thank you.
Well, and thank you for that segue, Delegate Lewis, because I'm Charlotte Davis, Executive Director of the Rural Maryland Council, and thank you to Bill for mentioning the lobby day. We do host a lobby day. Save the date, it's February 9th, Thursday. We do host, we schedule appointments with legislators, both rural, urban, and suburban. We meet with everybody across the state. They're 15-minute increments. We've done it virtually the last couple of years, and we've been able to hit about 50 legislators. We coordinate groups of, teams. So we provide talking points, bill numbers, and we will provide, a team leader. So we try to accommodate everybody's comfort level with coming to Annapolis. So please feel free to sign up. It is free. We will give you lunch as a thank you for your participation. So Thursday, February 9th, generally starting at 9 a.m. In the morning through about 12:30. We usually get great participation, so I encourage everybody, when the date rolls around, please sign up, and definitely Delegate Lewis, we will be contacting you.
Come and see me. You can hang out in my office. I mean, there are certain groups that are always welcome to hang out in my office. You can hang up your coat, rest your feet, charge your phone. Anybody who's working on transit or healthcare, always welcome in my office.
Oh, I'm sorry. The one you said,
Oh, and where we are doing is in Annapolis, but it will be virtually probably.
okay, the mayor, the lot. Asthma sucks. Where is that?
Well, we generally, so the last 2 years we've done it virtually, and it's been really successful virtually. Previously, we did do it in person. Like I said, usually getting into Annapolis at 8:30, finishing up just a half a day. It's not a whole day, but scheduling it because the legislators, they're available right before session, which generally on a Thursday will start at 10 a.m. So there's a little break there. But then early in session, they're still only in for about an hour. So then we come back at 11 o'clock with additional meetings until lunchtime, and then the delegates and the senators generally have to go to committees at 1 o'clock, so that's generally the end of the day. However, for folks that want to stay in Annapolis the whole day, there are additional activities, including the Taste of the Eastern Shore, which is also February 9th at the Graduate in Annapolis. So there are a number of events. There's Western Maryland PACE has a meeting in 19th and 20th of January, and then Southern Maryland delegation, Taste of Southern Maryland is March 2nd. So there are a number of events for the Rural Maryland Council. We also host a legislative lunch January 29th that has historically been in person in Annapolis downtown. So, but you all will be on our mailing list, so you will be getting probably those invitations. Like I said, these are all free, and so please feel free to sign up. And if you know of interested other parties that want to join us, they are more than welcome. So
Can I jump in one more time? So one of the few benefits of COVID is that it has forced the General Assembly to embrace virtual technology for communicating. And what we found, of course, is that with the ability for folks to call in on a virtual platform like Zoom, more residents, more people living in Maryland have been able to reach us and participate in the legislative process by giving testimony or whatever, joining in on some event. And I actually am sort of lamenting the return to normal because some are making the choice to stop using virtual communication platforms at all. For example, the Senate decided to cancel virtual bill hearings. And so to testify on a bill in the Senate, you have to physically come to Annapolis. Personally, I'm a House member. I think I can say this without getting into too much trouble, but I feel like that's less than fully democratic because it cuts off access of the people to their legislature. Folks in Dorchester or Garrett County who work, night shifts, they're not going to be able to drive to Annapolis and sit for 3 hours and wait to testify in a committee. I think, I hope that will change. In the House, we continue to use virtual hearings, and so folks can sign up to testify and do that remotely like this. And I think that's far more democratic and humane and just. But the idea of having lobby days and wonderful events like Taste of Western Maryland is amazing. If you can make it, definitely come. But it also underscores the limitations that our people have in far parts of the state, far from Annapolis, it is literally folks who can't get to their dialysis appointment, very unlikely they're going to be able to get to Annapolis. And so we've cut them off from access to their legislature, to the legislative process. I hope that this group of all the groups in the state can help us figure out how to create more just and humane access. We can't build a statewide rapid rail system, in the next 3 months, but we can, you guys could be advocating for access to remote tools for testifying. You could do a virtual lobby day where folks from far away can dial in on a phone. They don't have to have a laptop with the internet. Make it possible for them to talk to their legislators and let their legislators know, hey, I can't get my dialysis. I can't get my mom to her, chemo, so that they can hear it. And the rest of us can also hear it. It's just, I'm counting on you to be creative and fearless in the way you build connections with us. Okay, I'm gonna shut up. Thanks.
Thank you, Delegate Lewis. Definitely a lot of good information. I just want to say for all of those who are doing a lobby day or legislative day, if you've never done it before, you can't park at the actual building. So you will need to dress warm and have very comfortable shoes, because you're gonna have to park at the lot and a shuttle will come and get you. And if you don't dress appropriately, you're just gonna be very uncomfortable walking and trying to find places to sit. I've actually been someone who wore heels before to legislative day, and we used to do it faithfully every year with Community Mediation Maryland, and it wasn't fun. Go ahead, Bill.
I got one comment I'd like to make following Delegate Lewis's talk, and that is we have the possibility in this room, and one of the secrets that I've used for the last 7 years now, okay? I'm a member of the Carroll Community Media Center, and I've developed over 40 videos in the last 7 years. The cost to you is nothing. Okay, I'm a producer and a videographer, and for example, one of the things that I did, and I remember this, and a lot of my videos, they're veteran related, but you could use the same thing in your own area. We have, I believe it's like 60 or 70,000 people that watch Channel 19 out in Carroll County. We had, about 4 years ago, I created a program out there for Alzheimer's. And this was a community-related one. We had over 100 people show up for this presentation. And we had a psychiatrist from the Baltimore VA, and I forget his name at the moment. But we had a lady that was from the Alzheimer's Association. The community showed up, and here we gave this presentation on Alzheimer's. And I remember one of the things that the doctor had said, if they're in full-blown Alzheimer's, it's too late. But if you got the early signs of Alzheimer's, and you seek help, and I'll never forget that, because the people that were there, some of them were my friends, that I didn't even know that their husbands or their wives had Alzheimer's disease. So you could pick any topic that you want that would be able to help your community. And just like what we talked about here today, the opportunity to go out and affect your own community and say, hey, we need some help here for our mobility patients, our dialysis patients, but then you could put a video on your local media stations and say, hey, this is the impact that you're gonna have, because this is what Annapolis, people like Delegate Lewis are gonna be able to understand that, gonna say, hey, there's a great need out there, but we could do it in our own specific counties one by one. Thank you.
Thank you. All right, we're going to just take any last comments on this. Go ahead, Felicia.
So just another opportunity for legislative participation. The Transportation Association of Maryland will be hosting its annual legislative event reception on January 31st, 6 o'clock through 8 o'clock at Governor Calvert's house. And Delegate Lewis, we'd love to have you there, and anyone else who's interested in participating. January 31st, 6 to 8 at Governor Calvert House in Annapolis.
Calvert.
In Annapolis, Maryland. We will. We'll, Yolanda, when she sends the notes, this will be, we'll make sure to get all this information.
Oh, don't worry, my email's on there.
Okay, I just wanted to make sure to wrap up on our proposed policy statements. Develop regional partnerships, reinstate MDOT funding reduced in FY21 due to CARES Act. Does anyone have any comments or in favor or opposition of that?
My only thought here, Yolanda, is maybe step back a little bit with this policy statement. I think we touched quite a few additional areas of solution. So I think just funding generally is a big one. We also talked about braiding of transportation methods, including increasing allowable funding models. We also talked about workforce development and where and as appropriate limiting the variation among jurisdictions. So I think maybe for this one, we need to step back a little bit and not be so specific, but include a more general statement that includes these finite points that we've brought together.
I would completely add to that because, right now in the state of Maryland, our MCOs are not reimbursed for anything that's SDOH related, when it comes to either transportation, nutrition, food access, anything like that. And so I think if you pull out a little bit, right, like you're saying, and look at funding as a whole, I think that would be great because we have a lot of population that may not be able to access it just under the CARES Act. And we want to make sure that we're servicing everyone.
So Dawson, Kent County, excuse me. I think part of this funding piece, and I know it's a sticky issue, but lots. I think the state should have funding outside the lots to address what we're talking about because it basically does not exist. And we're talking about innovative solutions for transport. And when you look at the funding table and everything goes to the prescribed lots, your flexibility is not there. So that's an important point.
And just for our healthcare team friends, LOT stands for Locally Operated Transit Services.
As long as you're pulling out a little bit, one of the problems that we were trying to solve last year when the legislation was proposed was the fact that the federal paperwork takes way too long. When you are scheduled for a medical procedure, if your doctor calls you and says, we want to do exploratory surgery, we want you in there in a week. There's no way that a lot of these federal forms and even the state forms can be filled out. And the whole purpose of our legislation was a temporary for either 60, 90, or 120 days funding to allow time for the long-term solution, but we could do something temporary because you can't tell a cancer patient, well, we'll get to you, we'll schedule it 30 or 60 or 90 days from now for your biopsy when in fact they want to do it next week. So a temporary funding solution, which is what we were working on last year, might be helpful. It has a limited time life that gives the person the ability to go get treated and fill out the paperwork later was my suggestion. Thank you.
All right. Okay, so it looks like we got a little bit more perspective on this and also some, just pull back a little bit so that way we're not too specific and then possibly not addressing things that we could if we really look at it from a larger view. So with that being said, I don't see any hands raised, and I just want to make sure that folks online, if you do have something to add to this section, please feel free to put your comments in the chat box. But we're going to go ahead and move on to focus area 3. For those in the room, the contact information for the folks who wanted, it was Sarah, I think it's Sarah. At any rate, there's contact information in the chat box on Zoom that you all want to have, and so we'll make sure that we get that to you as well. Okay, so now we're going to move to focus area 3, and this is our community member characteristics, which a lot of this has been said already just because of these areas overlap in one way or another. And so for this, it's a lack of health transportation is a barrier to accessing health care, and coordination is critical for success, which we have all said in many ways. And so the issues identified here from our roundtable 2 were that inter-regional transportation for rural community members is important for basic treatment such as dentistry, and other basic treatment and preventative treatment was also discussed when it came to this. The other one was that, which we've already talked about, you might need wheelchair assistance or some other sort of assistance before getting into the vehicle and getting out. People talked about even having to walk folks up to an entryway or sit in a lobby and wait. So there's also the fact that there will be multiple people, maybe sponsors or support folks that are with them. And then follow-up care or community member transfer is difficult. And so I want to just allow Yolanda to say a couple more things, and then we're going to go to possible solutions.
Okay, this interregional transportation was a big issue, and I think we've already hit on that topic a lot, quite a bit. We heard also about the wheelchair. Some of the issues we've heard is, just simply carrying the oxygen tank to the vehicle. And then the follow-up care and the community member transfer, that was also referring to when a patient goes from one hospital and they have to go to another hospital, and if it's outside the region, it's even more difficult and challenging. Next.
The point that I'd like to add and suggest, and I do this often, is really thinking about how to frame this challenge. Can we go, yes, was it this slide or the slide before? Did we just, oh, please, yeah, sorry. So, it's a barrier to accessing healthcare. It also is a huge cost to healthcare and to the state. That's the piece that we're missing. If someone doesn't go and get that biopsy, if someone misses an appointment, the cost becomes not $100 or $500 medical visit, it becomes a $3,000 visit. So now that I understand it's a $3,000 cost to the healthcare system, would I spend an extra $10 on the trip? Of course I would. That's the framing that we need to make to legislative bodies so that they understand, yes, I'll invest $100,000 here to save $1 million there. If you just say this $100,000 here is tough, I need more, we are not going to make that breakthrough. So in what I've seen work is a very diligent effort on matching all the funding models, and that's what one of the things that we can do is, in our system, we just show you the funding models. Audit us, we welcome it, bring it on, because we show them you can reduce no-shows, you can on-time performance, your clinical staff is happier. All of these things, lifts the boat. So it's just a small reshaping of that.
I think it's more than just a small reshaping, because I brought this up in the first one and I haven't seen it. And what you bring up is the finance piece. We've been around healthcare and healthcare transportation for a long time. The people that we're not talking about at the table is also the healthcare providers, and having them. It's not always looking at the state to always fund the bill.
Yep.
And when you look at the healthcare providers, and we came very close, and then one of them dropped out, and it was a very large portion of the University of Maryland medical system. But when they miss an appointment, which is what we hear all the time, that's costing hundreds of dollars every 10 minutes.
Yep.
if, when you get them to take a look, and they need to do the analysis or work maybe with this committee, and I think that's where we have to kind of go. We got to do that data analytics here, and get them to work with us and go, okay, because there are other places in the country, when we took a look years ago, that actually hospitals build transportation systems. And we talked to our local a while back, and they don't want to, in Maryland, they don't want to build the system, but they could help fund some of our systems that are already there and work hand in hand.
So Courtney can add to that specifically, because that's exactly what I'm commenting.
Yep.
So Courtney and.
So back in about 2013, the Western Maryland Health System, which is now UPMC Western Maryland, worked with the Community Action Agency there, which I was the executive director at the time, to do a mobility management pilot, specifically around high utilizers of the health system, inappropriate use of the emergency department. It was successful and expanded out. It still exists today. They are the primary funder of a lot of our non-emergency medical transportation. They still work with the Community Action Agency. There is, I'll call it, a technology platform that is utilized, that the providers are able to access and input patient information. The challenge that has been in place is that small pilot, working with a small group of people that they were able to track over time, they were able to justify that they improved health outcomes. What's happening now, and it's more challenging because now they're serving a larger population. People in the community have heard about it and can self-referral, and they've wanted to be able to make it as accessible as possible for everyone. They've lost some of that ability to really show that the money that they're investing in the transportation piece is really improving health. And that's why we're also looking at, what else can be done? Because if they would choose not to continue that service, our limited transportation infrastructure now that doesn't meet all of the needs would be significantly reduced. But so it gets back to, yes, they need to be at the table. I think they would be if we can make the business case. But what are we going to measure, and how are we going to measure it? And when we're looking at a lot of the smaller nonprofits to manage this, they need the technology and they need the resources, which are people. And oftentimes they don't have the staffing to be able to do a lot of this work.
We have been trying to tap into Partners in Care. We're right down the street from Baltimore Washington Medical Center, AAMC. We've had a couple of conversations that really haven't gone anywhere. We take hundreds of people, either to the Tate Center, to the hospital, to all of those medical facilities right there on Hospital Drive, and trying to make the case and having some inroads with some of the folks. They agree. When people miss their appointments, that's money. And when people are able to make their appointments and manage their health, that's a reduction in costs. But I tell you, it has been a tough nut to crack to try to get them engaged and involved. And yes, there's an outlay of financial support, but what you gain in the long run is far more than what you invest. But it's just trying to crack that nut. It's tough.
All right, Bill Murphy, Friends of Disabled Veterans of Carroll County. I'd like to just add some remarks onto this. I was on the Center of Study for the Aging out in Carroll County for over 10 years. And myself, I'm 77 years old. And the most important thing that we could do to reduce the cost of health insurance is do some preliminary things amongst yourselves. For example, I'm a diabetic, have been for the last 22 years. And about 5 years ago, I started with a program through the VA. It's called MOVE. And since that time, I've lost about 38 pounds. And these are things that you could do, and my A1Cs come down considerably. I exercise, I watch myself. And one of the biggest problems that we have in the United States today is the weight we have. A lot of my patients, the vets that I have, some of them are over 400 pounds. And with this additional weight that they have, it's just it causes havoc for your system. But if you lose that weight, and there's things that we could do ourselves. But I think the other thing is losing that weight, but the most important thing is a positive mental attitude. I worked as a medic in the Air Force for 5 years. I worked for a doctor, and he said, Bill, he said, the most important thing that you could do, regardless of any disease that you might have, is a positive mental attitude. And you do that, and things are going to work out for us here. Just feel good about yourselves, and things are going to work out. Thank you.
So in conjunction with the missed appointments, wouldn't coordination with the readmission rule actually be one of the key ways that you can convince healthcare systems to become engaged in this? I know from an EMS standpoint, that's how pilot programs for community paramedicine and community health actually matter. And unfortunately, it flies in the face of federal funding because it targets specific populations. But if the state were able to enable funding for target populations as a pilot with the intent to expand public-private partnerships with healthcare systems to get those, you have to start somewhere, and it has to be meaningful to each side of the fence. So I would say that readmission rates is probably a great purchase point for this.
Yeah, I would totally agree with you, Andrew, because, I mean, the reality is that the hospitals, because of the readmission penalties, have a vested interest, right? When it's a Medicare patient and they're paying upwards of, $20,000 for that readmission, commercial, 50, but they're not penalized for the commercial, right? For Medicaid, it might be another 10,000, I mean, there's a lot of penalties that are associated with this. However, the hospitals are stretched right now. They are doing everything just to survive. Their operational costs have gone through the roof in the last few years because of COVID and having to bring in additional staffing. And, again, I'm an MCO, but I've been in clinical care for 30 years. I can tell you, I've never seen it like this. I mean, I know so many people have left the industry. They can't fill positions. I mean, we're owned by 4 health systems in Maryland. We're owned by UPMC Meritus, UPMC Western Maryland, Meritus, Holy Cross, and St. Agnes. And each one of them has 200-300 recs that they can't fill. And so they're bringing in travelers, and they're having to pay those exuberant salaries. Yep. Now their own staff is saying, well, why are they getting paid more? And they're having to raise their internal rates. So the money that they have is few and far between. That's why so many hospitals are folding.
Thank you for that. Really quickly before we take more, we want to just go through the possible solution slide, since some of the things that you've already said are covered here, and I've also heard things that are not covered here. So, and then I'll see your hand.
Okay, the first possible solution is to develop a program that supports interregional transportation for healthcare. This would be something new, that would be a possible solution.
Can you explain that for me, interregional transportation?
Sure. This came up a lot in our last meeting. Interregional means someone from a rural area who needs to have specialized care in a more urban area. We heard a lot from last time, especially in the western part of the state. Basic dental and dentistry is limited in Allegheny, Garrett County. And
I think you need to spell it out more then, because when I read interregional, to me that just means county to county. And our transportation provider, Shore Transit, does 3 counties. DCT does 4 counties, and actually partners with others. So automatically, I just didn't know what you meant. That's why I was saying that. When you say interregional, these guys, DCT takes people up to Annapolis or Queen Anne County ride goes. So I think we need to be, if it is going from rural to urban.
Yes.
Absolutely. I just think we need to spell it out more, that's all.
Yes.
It can actually be county to county, because we've got plenty of patients that seriously, they're in PG and they won't even take them to Baltimore County. That's a problem, especially somebody who's had some sort of specialty surgery at Hopkins.
And you're exactly explaining my point.
Exactly.
You're sitting in a rural Maryland council meeting, and no offense, what you're talking about is not rural, And we totally agree and we totally support what you're doing. It's just that it means something else when you're coming from rural. So we just need to spell out all that. That's what I'm totally with you.
And
I
so
just think
it-
it's the wording that we need to make sure that certain legislators here and other legislators, and we get everybody on one page, because Lord knows Baltimore City has the same problem as Dorchester County. It's very close.
And I will tell you that we're statewide, and 85%, we own 85% of the Medicaid membership in Western Maryland, and we have the same issues, right? We have people out in Garrett County and Allegheny County who have to now travel to Washington and Frederick and Baltimore, and they're stuck in the same issue.
Totally
So
agree.
I agree with you, it's statewide, but please don't think that I'm solely representing the central region.
No, but that's what I mean. That's why we have to make sure our wording is correct, because when you get it into.
where I am, which is a rural meeting.
No, and when we're going to legislators to explain it, we just know that we have to make sure that when we leave, whatever wording we're putting on, that's what I'm trying to say.
But to that point, Scott, I think it is good to really be very clear, because even in Western Maryland, we're not nearly as good at coordinating that transportation as the shore is. So Garrett County will bring patients into Allegheny County to receive services, and then they'll go back to Garrett County. Allegheny County doesn't meet at the line and change the transfer. And then the same with Allegheny County going into Washington County or further into central Maryland. Everyone sort of operates within their own silos.
Yep.
Thank you, Courtney.
Okay, I'm gonna let Yolanda finish. Is there anything else for interregional transportation that you wanted to highlight?
No, I just wanted to point out that I think earlier we had heard comments about some of the high costs it was that it would take for someone who needed to go from a rural area to the more urban areas, and trying to address that. And the next item would be senior community members have unique health and transportation challenges. That came up a lot at the last meeting, the senior rides program that we have. And the last is consolidate a resource list of programs and methods for follow-up transportation.
And again, we definitely heard, we need to get healthcare providers involved as well in that system. And so we're going to go to our proposed policy statement slide, not our final comments, and talk a little bit about that. And we want to hear from you all as well on this too. So here you go, Yolanda.
Okay, the first item would be codify a new non-emergency healthcare program in the Maryland Department of Health that supports interregional, which we can define better, transportation, but mainly from taking people from the rural areas to the urban areas. And I think it was mentioned earlier, a bill that was proposed, HB 1243, that would have last year that would have accomplished that goal. And the second one is increase the funding for senior rides. The senior rides program was originally established with a maximum limit of up to 500,000. At the last meeting, we heard it's funded at about 187,000. Yeah, so it's very, and I can tell you that the demand for it's much larger than what's supplied for it.
Can we define the age group, also put in? Can we make sure we put in the age group for the senior rides? Because we talked about this last time, which is, I think. Okay, perfect, because that does cover a portion of the Medicaid population. That's why. You have a mic.
And just before you say that, again, the age is 60 years of age or older. And then, so we have Nancy and then Sarah.
I promise not to be long. Sorry. Medicaid. Hi, I am a recipient. Oh, well, shoot, I am 60. But I have picked up recipients that are 30. So it is not, it's not an age thing. And when we talk about Medicaid, we talk about the other funded things, it's that age, the demographics, these people, race, creed, color, inclusive. As, oh, wait a minute, Sharon? No. No. Charlotte? Sharon. I was right the first time. Hey. Sharon had said that accessibility has to be broadened. And to sit there and just throw, oh, it's just Medicaid or Medicare people. No. Yes, they seem to be the bigger population with different disabilities and unique situations. But like you said, dialysis, I'm sorry, I've seen dialysis patients in their 20s. It's something that needs to go and expand to incorporate anybody of those special needs and special, I call them special circumstances, that's my word, to incorporate all them and not to forget any of them, because they have a need. This transportation is not an age thing. It's a broad spectrum, and boy, we're going to do a lot in this group, aren't we?
So other thought here, again, I think is to step back a little bit on, I think senior rides has come up across all the meetings, but we've also talked about some other special populations. So potentially this policy statement can be broadened to focus on priority populations that we know lower cost of care if we focus on preventive and chronic conditions going in. So those readmissions, we've also talked quite a bit about substance use disorder and recovery. That's going to be a Maryland Department of Health priority because we're seeing such an impact on long-term health outcomes and quality of life, along with seniors. So again, if we can broaden this statement to focus in on data-driven priority populations, I think that would be important. And if there are specific dollar amounts that come along with that, maybe that's a subset of statements.
Yeah, I really appreciate that clarification, because if we stay too narrow to the NEMT Medicaid funded only, there are many other needing communities that will be excluded. And so all we're simply doing is creating another silo. And with rural communities, we don't have those resources to create 8 different silos to get my mom to the hospital, you know, and it's just something that we really have to take from a broader approach. It's exactly what you're saying. Here are our communities in need, or our neighbors that are in need, and here are the best kind of solutions for each of them in rural and the blending. And then we want a platform or some way, once the human issue is taken care of, that we can build back to the right program. That is where you lean on technology to just account for it in the right way, bill to the right person. Don't worry about that. Tech has that hands down. And then I think from there you begin to put something forward.
We have one hand online, A. Levine.
Hello again. Thank you for what the two
Sorry, say your name again.
This is Andrea Levine.
Andrea, okay, thank you.
So just to piggyback on what was just said, and also in the first roundtable meeting, when the point was made that Medicaid non-emergency medical transportation is really only 50%, if that much, of the populations that we are trying to help with these social determinants of health. So if you can go back to the policy statement for a moment, I would recommend considering for that first bullet point, when you have it up.
Can you see it? It should be are you sure? Who has a Zoom? Okay, he's gonna share it now.
Thank you. There you go. When you talk about codifying a new NEMT program, if this policy is intended to broaden from what's already there, you may want to consider not using the term NEMT with the Maryland Department of Health for the purposes of keeping it from getting confused with what's already in place. And to piggyback on what was said by the two people who just spoke before me, would be some type of suggestion of maybe specifying for those not qualified for Medicaid transportation or for those not enrolled in Medicaid. Because I think much of what I'm hearing about the need for transportation across regions and counties and jurisdictions throughout the state are, while they may not be perfect, are somewhat being met at the moment by Medicaid, and we certainly aim to increase meeting all those benchmarks. but I think you've identified a very needed area of further support throughout the population of Maryland and outside of those who may or may not qualify for Medicaid.
I appreciate that statement, and you're absolutely correct. And me, not in the healthcare field, constantly make that error, and Sarah constantly corrects me that non-emergency medical transportation, when I think of it, I'm thinking everybody, but for our healthcare friends, it's a very specific program. So again, absolutely, I think you're absolutely right. We need to, take that word, that nomenclature out.
And Andrea, please don't take this the wrong way. I can appreciate the services that you guys do provide, right? But if that were true and the needs were being serviced for our Medicaid population, I would not be sitting here today. And I can honestly say several of my colleagues would not be sitting here today as well. This is a pain point we face every day by every single MCO in the state of Maryland. It has been discussed multiple times amongst us, and if the need was being met, again, as you say, the example that I had before of one county to another transportation is a Medicaid person, and we see this every day. Our care management team runs into it, our social determinant of health team, our hospitals run into it. So, I appreciate everything that you guys are doing, and I've already sent you an email, but I'd love to have a meeting with you personally.
So what I read in the policy statements I think it lacks context, because I look at the $500,000 number and I thought, wow, I wonder what the ceiling, oh my, that's all you have for senior rides? What does that do? Not much. And I do not believe it, so the $600 ambulance ride, well, it costs $600 to produce that level of work. Someone has to pay for it. So if we charge them nothing, if we charge them $10, if we charge them $100, at the end point, there is an entity paying that cost. There is a measure of work and a dollar attached to it, and I feel like it's not that I didn't, until I got into transit, understand what that number is. So $100 an hour represents an hour of work. An average ride from a rural area to an urban area to get treatment and then return to the rural area might be 8 hours. So that's an $800 trip. How long will $500,000 serve? That won't work for my area.
And they're not even, that's up to, right now for the last few years, it's only been
187.
Yeah, well, that was the part that made me choke even more. I thought, when you said,
right.
What?
So
what are we doing with that?
Let's keep following, the economics. I won't say the money, but, the economics. In trying to also understand, I just came back from a Medicaid conference in DC this week, and, they talk about the transportation utilization. So MTAC came out with this report, and it's like 14% of Medicaid beneficiaries use the NEMT benefit. It's negligible. And so these are people that we know don't have the means, and at the highest rate, it's 14%. In some,
Thank you for making my point, by the way.
but let's talk that data. It's used. We use phrases to describe it, but let's use a number. At the biggest state participation rate is 14%. Average is about 8%. So how are our members getting the services that they need?
It's a great question.
through other agencies, through other agencies like ours. We get,
Yeah, sure. You gotta speak through the mic. Give me one moment. We wanna make sure we only have less than an hour left.
Okay.
So we wanna make sure that we do at least acknowledge folks who have been waiting. I know Yolanda's been waiting, and
Right.
then if Sharon.
Okay.
Sharon will be next.
I'm probably going to steal some of Sharon's thunder, and I apologize, but
It's
Senior
okay.
Rights operates with volunteers, that mostly operates with volunteers. And think of that, the state is getting for $187,000, I think it's over 32,000 rides a year. I mean, for that, and because they're operating with volunteers, and Sharon at the first meeting gave an excellent presentation of her program, Partners in Care, and the enabling legislation's there. It's just a matter of putting it in the budget, and so that saves you $100 a ride.
Yeah, and the thing that I don't get, we get customers. I have a customer who lives in Annapolis. She goes for PT in Tyson's Corner, Virginia. Hello? And so we struggle to try to find a ride for her because she's exhausted all other avenues. She doesn't have a car. She doesn't drive. She doesn't have family who can give her a ride. So when you look at, and she's not the only one. I mean, some of these insurance companies are sending people 2 and 3 counties over to get services, and they're not getting it, because they can't get there. So this is such a huge issue on so many levels that we could probably talk about this till we all pass away.
I think we probably had this chat each of the roundtables as well, that here I think too we need to build in those supportive resources. I see this as perfect work for advocates and community health workers to be able to sit down with an individual and say, this doesn't make sense. We're going to have trouble finding you transportation, because let me have that conversation with you and your health insurer to find the PT that's 5 miles away versus, I can't even guess how far Tyson's Corner is.
A long way.
So I think here too, again, we have to think about that staffing and coordinating. And I also wanted to make the point, I don't think this shouldn't all fall on the state either. So I really think that braiding becomes really important, because I think there's a place for nonprofits, and I think that's somewhere that we're so strong in rural, in Maryland, across the country. So I wouldn't want to ever cut out that component either, because that's what holds communities together. So I think there's work there to always be done. So that braiding, but also we need those advocates and community health workers, how they get funded, that's a question, but we need to build that into our solution.
Thank you. Bill and then Lorena. Go ahead.
I'd just like to say, as far as the solutions to that problem, as far as going so far away for appointments, I think it was in 2017, the VA had a very terrible situation that they were people were dying, waiting for an appointment. So what they started, President Trump started what is known as the Mission Act. And what the Mission Act did is that if you don't get an appointment within 28 days, that you would go to a local provider approved by the VA. And that necessitated not all these appointment problems that they had in the VA. And they're still doing the same thing today. It's called community care. And I was waiting for glasses for over a year through the VA. And finally, I complained to the VA, and they said, well, you can go to a local eye specialist to get your glasses. The only thing is you have to go to the VA to get the glasses itself. And it saved me close to $435 for these glasses. So it works. And maybe that idea could follow through with our insurance providers, because a lot of them are having financial problems just like anyone else today. When you have this terrible inflation that we have today, to work better to get her. And I have a friend of mine, he's with Johns Hopkins, and I'm sure that's a very, very large facility here in Baltimore, and he's out in Carroll County. But if you have more interaction between the different insurance companies, it would be able to save tremendous millions and millions of dollars in cost. Thank you.
And I don't disagree with that. I guess because I'm the only insurance representative sitting in the room, I'll kind of answer some of the challenges. So this gets down to providers, and providers being willing to accept Medicaid. Not everybody is willing to take it, right? The second piece has to do with specialties. So not everybody's going to have the same level of specialty. So if somebody needs a certain service and they only offer it down in Tyson's Corner, there is no other option, right? If they've got a special chronic disease or some sort of situation that they have to go see that specialist, and that specialist is the only one that's around in the area.
For PT.
Yeah, for physical therapy, right? Well, there may also be an issue where the other physical therapists, right, are contracted and they're out of network or they're too expensive, right? So there's a lot of challenges, again, that have to do with network contracting that go beyond being able to just go to the closest person in perimeter. Getting back to a point that you gentlemen made, I, like many things, right, and to your point, right, they had to go out of the VA in order to, service what was needed. This is going to be solved with private and public partnerships, and we're going to have to really start looking at how do we bring a coalition of people together that can look at it from both the public, the policy piece, right? And this is a dichotomy. I mean, I have a doctorate in public administration. Everybody always asks me, why didn't you get a PhD? I said, because I'm an applied scientist, right? I want to actually, not theoretically, pontificate over it. I want to be able to apply, what I've learned. And so part of this is, policy gets written, but how somebody else is going to have to enact it, right? So maybe putting the policymakers, the people who are actually going to have to drive those policies, and the private industry in the same room, and then having them figure it out, we might actually get somewhere around this. So.
It's definitely been a lot of good comments, and we're going to take a look into that. One of the things I want to kind of bring us back to, just to see if anyone has anything else to say on it, is in reference to, our terminology that we use in that first bullet. And Yolanda already indicated that, we've talked about what to call this so that even if whether you're in the medical world or not, it's understood and defined. And so we want to just see if there's any other ideas around what we should call that. And then, of course, we've already identified that the senior population is not the only population that needs assistance, and age definitely, should not be the only quantifier for that. And so, anyone else want to contribute a comment or have a question about that, or any ideas around what we should be calling this type of transportation, or what should be in this policy statement? Online, you just raise your hand. Go ahead, Bill.
Okay, I just got one comment that I'd like to make, and I'm involved with the VA pretty heavily, and I remember this one, she's a nurse and she's an advocate for veterans, and she says it's extremely important that you be a wordsmith and watch what you say, because this is Lorena said today, she's a policy expert, and if you... Okay.
She said she's with the insurance.
I rescind my comment, okay? But this lady said you got to be very specific when you're looking for pension and compensation with the VA. And it's one step. She made the analogy of this fellow that said, yeah, I could go up the steps or whatever. But she said, no, you can't walk up the steps. You could do 3 or 4 steps, and that's an important saying that you have to put that down in paper, because that could nullify your claim. And it's the same thing what we're doing up here. It's extremely important that we do some good wordsmithing in there to make sure that this meets what we're talking about here today. Thank you.
Absolutely. Go ahead.
Since Tri-County Council tried to get a facility built, and nobody wanted it in their backyard, so we decided that instead of building a slaughter facility, we would build an abattoir, which in French means slaughter facility. I would suggest maybe you just use the same term in a different language, and everybody will know it means the same thing, but it's not the same thing. And so maybe you look in the French dictionary and look up non-emergency medical transportation.
Lorena and I are both from Montreal, so we'll speak the French part.
I am a U.S. citizen too, though.
Look, health and human service transportation. I mean, let's borrow what is already in place. Because one part of the funding is Medicaid and NEMT, and there's so many other needs in our community. What we're trying to do is break down the silos. We're trying to say that if I put in $1 and you put in $1, that might actually be 3 or 4. And we can't keep duplicating small capabilities in every single county. We can't afford it. The one thing that, what we have learned from COVID is that we have to actually pool the resources. We have to get very laser focused on individual needs. We also understand that the language in which we go back to legislators needs to be numbers driven. Back to our health plan partners, insurance partners, we need to show them that a missed appointment, 26% of booked trips, we know that it's more than enough trips are not ever booked, but 26% of the trips that are booked are missed. They don't show. That is a huge cost to the system. So there's more than enough money if you reduce the inefficiency and you do a dollar for dollar share. Give me $1, you get $1, there's going to be 6 more in the kitty.
Thank you. And someone mentioned money before. I think it was you that said when that $500,000 would not be enough. And so I want to go to Sarah, but as Sarah's talking, think about what is enough. Like, what is a number? Can we even think of one in this room? Go ahead, Sarah.
Sure. I also wanted to get a little bit more specific here in, I think, Health and Human Services Transportation Program. I think we also have to be very specific, again, wordsmithing in language, because a program that supports could mean provision of services. It could be more of that hub and spoke idea that we, I think, talked about at the second Transportation Roundtable. So if we can have some conversation around what would this program do, from my point of view and the conversations that we've had, I definitely fall towards liking the idea of that hub and spoke where there's that subject matter expertise that somebody mentioned. I think maybe Scott, you were talking about, and training and patient education, those resources, someone who understands the wide variety of inventory of funding, who can help provide that training and conversation with regional and local jurisdictions, not necessarily provision of services, maybe could be the holder of some funding and distributor of funding. But I think we need to converse a little bit more about that before I'd feel comfortable keeping this one on paper as is.
Thank you, Sarah.
And I think the question about what funding we need is a very tricky one, because I think there's a lot of money that's going into transportation now in the state by the various agencies, especially some of the smaller nonprofits and faith-based groups, that we really can't quantify. So I really think we need to sort of asset map what exists in transportation, but then also look at the dollars that are going in. Because until we get to that point, we're just going to be guessing at a number to come up with something that we think will work and we could be adequately off of target.
What if it's federal funds, you can look at 5310. That's
Right.
nonprofits, that's the churches, those are all those. One of the biggest challenges is churches are not doing what they used to do. So I'm from a small rural town in North Carolina, and when I was a kid growing up, church was open all the time. Churches aren't open all the time now. You might be there on Wednesday, you're there on Sunday, because we've been trying to break into that faith-based organization to develop relationships with them, to get volunteers, to help us provide some of the transportation services. The other component is some of these agencies aren't getting as much money as you would imagine, and they are trying to match and leverage what we get through the federal government, what we get from foundations, what we get from all the other granting organizations out there that we're trying to gather dollars. Transportation is expensive. It is extremely expensive. Do you know what a paratransit ride costs for one person? Mm-hmm. I was the director of mobility 10 years ago. And during that time frame, we were somewhere between $70 and $85 one way. One way. And on a busy day, we could do 4,000 trips. So it is very, very expensive. And so to the degree that we can maximize using, as I talked about before, a family of services. Public transit can't do it by itself. Nonprofits can't do it by itself. Health departments can't do it by itself. We've got to work together or we're going to be stuck with the same thing that we have right now. And so until we all kind of come to the table and be willing to share and not hold out a little bit back, we're going to be in the same situation we are now. And one of the areas of opportunities that we can look at, somebody mentioned workforce development. Right now, transit systems are having a difficult time keeping drivers. And in fact, some transit systems are cutting service because they don't have the drivers to operate. Let's bridge that workforce development, and let's look at transit system in terms of operators, and let's try to work together, not harder, but smarter.
And I agree with that. So I'll come back from my, my previous role with the Community Action Agency. We were also the Area Agency on Aging. We tapped into 5310 funds. We also contributed a significant amount of money from other grant sources to transportation that was sort of lumped under administration. And we were a larger organization, about a $14 million community action agency. And we knew what we spent on transportation. But there's a lot of smaller agencies that run transportation as part of the service they provide to get people in their doors, but they're not getting dedicated transit dollars, and they don't quantify what it's costing them. And so what you see, at least in Western Maryland a lot of times, are these what I'll call 10 and 2 buses or smaller vans, a lot of them wheelchair accessible. And they are traveling literally the same routes, half empty, within minutes of each other. And then behind it, we see our public transit buses, large buses, oftentimes with the only people on board as the driver. But again, I agree. People don't want to come to the table and share what they have because everyone's very protective. But we're going to get to a point with both workforce shortages and resources coming in our doors that we're going to have to work together, and we're going to have to find out a way how we can better coordinate. And if we have a community action agency that's transporting people to adult medical daycare, and as part of that service also going to medical appointments, why couldn't they also be working with the DDA facility that's doing the same thing? They're working with vulnerable populations, and they have staff that are trained.
Thank you so much, and just definitely want to just acknowledge one thing that you said earlier, which is really doing like an asset map, figuring out where the money is, how it's being appropriated, and really just understanding the inner workings of how that money can be used, how we can expand it to cover other things as well. And so I see another hand in the room. We can go ahead and use that mic right there.
This was to speak to workforce. You can give me $1 million right now and I can't do $100,000 more worth of work with it because the workforce doesn't exist. I would say that something that would be beneficial, transit drivers everywhere in this state, there's a shortage. If the state were able to help us make an attractive employment package that makes transit a career, and as a group, as a statewide group, we understood that and would manage the wages effectively, because I've watched healthcare systems battle it out. I can't compete with my local operation that's going to pay drivers $4 or $5 more an hour, because that's going to cost them an extra $10,000 a year. It's going to cost me an extra $350,000 a year due to economy of scale. So the point being is that workforce is good workforce that's already trained, that is professional and appropriate for the tasks at hand. That's something that synergistically the group has far more strength and can really make it a statewide position, if you will. I've seen that effectively work, but that's the challenge in finding people. Why would you want to come work here when you can go work at Walmart for $1 more an hour out of high school and get full benefits, and I can't afford it?
Yeah, Andrew, that's actually an excellent point. And I think part of that, is looking how do we change things up so there's more flexibility, right? And it's a more appealing package. Because one thing that I know personally is that I know a lot of people who have taken pay cuts because they'd rather work from home, or they may have, some different flexibility. They can job share, right? And so I think we've been very rigid, in some of these positions. So getting creative is one. We recently did a program, we've created as part of our SDOH side of the house, Pathways to Healthcare program. And part of this has been a partnership with our health system owners, because they can't fill those recs, right? For environmental services, for nutrition, for transporter, for clinical observers, and so forth. And so what we did was we looked at our Medicaid population and said, all right, guys, who wants to work, right? And then found Goodwill Horizon out in Western Maryland, which is a phenomenal partner of ours that has a workforce program. And Meritus Health, us, MPC, and Goodwill came together and said, let's do a job fair. And you, Goodwill, are going to train them, and we're going to use some of our funds to pay for their pre-training, because you can't take somebody right off the street and put them into a healthcare environment. So, like you said, some people need that additional training. We have to be willing to offer that and to start paying people to get those skills, right? And then transition them into, those better paying jobs. So, I mean, that's the way that we looked at doing it, is let's take people from Medicaid that want to work, right? And move them into meaningful employment, give them the skills and job coach and mentors. And then at one point, we're even going to give them a bonus and start them with financial literacy, so that now you're helping them grow.
Thank you. Before you go, Bill, I just want to to see if anyone online does have a comment. There was something in the chat from Ms. Simmons, or M. Simmons 1, that we are experiencing, so you, Sharon, we're experiencing the same lows and highs, only makes sense to work together. CDL versus non-CDL holders is a difference maker when hiring drivers. That's something. And then we wanted to let Yolanda just wrap this up. I know you have a comment, Bill, and then we're going to have Bill start it off our final comments.
Okay, just next step will be for me. Well, first let me start by, we were talking about numbers and things like that. I wanted to mention that 1 out of 5 missed appointments is because of transportation, and that's based on national statistics, and I think I'm speaking to the choir here. We at Tri-County Council for Southern Maryland manage a small program called Wheels to Wellness, which has been supported by the Rural Maryland Council. Thank you very much. And just what we, as part of that, to try to demonstrate what savings we have with our patients, we are requiring the hospitals to come up with CRISP reports, and I brought copies of those reports. We are finding the pre-post analysis reports that we are saving 50 to 60% of the budget of the comparing the post versus pre. I have those reports if you want to look at them. Also, I mentioned earlier, I've heard that over 50% of some of our paratransit budgets are for dialysis patients. There is a strong need there. And also, another statistic to bring up is that at our first meeting, one of our, it was a EMS deputy fire chiefs had mentioned that 80% of their trips are basically non-emergency medical transportations. Sometimes they come to the ambulance with a suitcase in hand. I mean, we were talking about efficiencies in the system. That right there, I think it shows that there is that. We can find that. We are proposing policy statements. If there's something that you would like to bring comments, be sure to forward them to me. I think you all have my contact, telephone number and email address. It's right there, yhipsky@tccsmd.org. My telephone number is 240-682-1108. 240-682-1108. I'll be happy to take those comments, and we will be writing over the report. I'm hoping we should be getting it done and completed by the end of the year.
Thank you, Yolanda. And we will start off our final comments with Bill.
All right, I'd just like to follow up with what Lorena just talked about. as far as a private-public organization working together. I had the opportunity last week to go out to Platoon 22 and Goodwill of Monocacy. And they have a facility out there, which is a multi-million-dollar facility out in Frederick, Maryland. And we hope to be working with Danny Farrar and his wife, Nikki, as far as transporting veterans out there. And this is a partnership that was greatly needed. Like, they have 20,000 vets out in Frederick County. And I was out there for the groundbreaking of it a little over a year ago, and it's a fantastic operation in there. And not only do they have both of these organizations working with workforce development, but also with PTSD. And what we're doing here, we're going to be working with Danny and Nikki as far as transporting the veterans back and forth out there. And they have, for PTSD, they have the counselors from the VA that are out there with them. And for those of you that are not aware of it, today in our society, we have 22 veterans a day that are dying as a result of suicide. So it's 1 out of every 5 suicides in the United States that they're veterans. So this is the type of things that we need to do here in the state of Maryland, to work more private and public partnerships between them, because we'll all be the benefits of this by working together. Thank you.
And Bill, can you just, I know you mentioned Danny and Nikki Farrar.
Yeah.
For those who are not familiar with them, how can folks like look their information up, or at least see what they're doing in the industry?
You could look on the internet as far as the Platoon 22 in Frederick, Maryland.
Okay. Platoon 22 in Frederick, Maryland. Okay.
Or just look up Danny Farrar or his wife, Nikki.
Is that D-A-N-N-Y or D-A-N-I?
I think it's D-A-N-N-Y.
Okay, thank
Danny
you.
Farrar.
Thank you.
And they'll be able to find them, and it's quite an important facility, because it's especially for the veterans that, when I was out there were actually veterans that were out there that saying, hey, we were trying to get some help with the Veterans Administration for 3 or 4 or 6 months, and this will be a local one that will be able to walk in there, because they're inundated now, the VA, with PTSD problems throughout the United States.
Thank you so much. Anyone else have any final comments online or in the room? Okay, well, we have definitely had a rich discussion today that has been very productive. And as Yolanda already mentioned, please give any additional comments, questions to her, feedback by December 1st, 2022. At that point, she will definitely take all this into consideration as she's indicated, and I'm going to let her speak to it. It's definitely going to be included in the report, and we hope to have some really thoughtful policy statements that really give the understanding to everyone, because again, there's different words that are used, but it has different meaning depending on where you're from. And I have to say this, as Nancy said, no one chooses to be sick. So we all need to come together and help. So here's the.
Amen.
Just as we're moving through with this, is there any of the policy statements, are there any ones that stand out to anybody that they want to comment on, that they think is extremely important, or if you could rank them? And I know we've covered a lot, but any points that you would like to see emphasized a little bit?
So, I know that we're placing dialysis up there, and there's tremendous importance in the dialysis piece, right? And I think, again, they're the repetitive users, right? But we have many other populations that also need those resources that may not need them as frequently per se. And I'd be remiss if I didn't bring up the point that if we solely box in on the dialysis, then we're going to make sure that that group gets their need met, and we may not highlight the needs of everybody else. There are plenty of people on Medicaid that do need those services as well, and on Medicare and veterans and so forth. So, just that dialysis piece. I know that we want to bring special attention, but it's not just on frequency, it's also the basic need of the broader population.
Maybe we should go through the three, proposed policy statements. Yeah. Okay, this is reestablish the State Coordinating Committee for Human Services Transportation. How do y'all feel about that?
I think that's an absolute category that we have to do that.
You need a body that's responsible for this.
And make sure that it is representative of the unique characteristics of Maryland.
Am I here?
Not just that, payers, hospitals, just all of the.
Payers,
all of
hospital,
these stakeholders.
transit agencies, and organizations, so both a
Private,
user
public.
and provider.
Okay. Am I hearing a consensus then? Okay.
And I think it needs assigned to an entity.
Yes.
Okay. Yes. Who?
I believe it's under MTA.
Right.
Is
Right
this,
now.
This existing, the State Coordinating Committee for Human Services Transportation's under the Maryland Transit Administration.
And right now, the areas where they're covering is agencies, aging, disabilities, schools, Secretary of Health, Housing and Community Development, Labor, Planning, and Transportation. So those are all key areas.
I think I heard a consensus that we might want to revamp that membership.
And it sounds like that's at the secretary levels. And so I'd say Department of Health, you've got at least, 10 administrations under that have their own areas of responsibility that are very far outside of the one person that the secretary might designate.
Okay. Okay, good, great. I think we're hearing a consensus to reestablish the State Coordinating Committee and to revamp the membership.
And I would go a little further instead of just reestablish, but codify, because this body was created under an executive order, and that's why it has been allowed to kind of drop off. Whereas if it's codified, it gives it that oomph in state statute that this is an important body to the administration to make sure that they complete their work. And I did want to, and when I was doing the review of the committee, the report they issued in 2016 said that they were going to do an inventory. So I would recommend, instead of tasking 211 to do that inventory, that perhaps the State Coordinating Committee should be that body that does the inventory.
The only reason I completely agree with you, spot on, is because, as I mentioned before, many of us at the MCO level and health system level are not using 211. We actually have our own platforms. And so I think you need to convene a higher body, right, to actually inventory those resources and send it out across. When you talk about codification, I also believe that we need to make sure that it's not only to those secretaries, right, that we include a broader range and we really start driving and pushing those private public.
And so I generally say with tangible deliverables and resources in which to do it.
Correct.
I know a lot of our administrations end up with projects and absolutely no resources. I have 3 commissions this year with no funding or extra personnel. So I think that's extremely important as well.
Resources.
Or at least a study, common data study to find out
that you can pay a vendor for.
The true cost. Common data study for what the true cost of failed transportation is, right? Whether it's from the hospitals, the MCOs, the missed appointments, just go down the line.
That probably already exists, but yeah.
Okay.
Where's health outcomes, better health outcomes, what's that value to the city?
They've done some of that.
Okay.
If they haven't, it needs to be.
Okay, I think I'm hearing a consensus to task the inventory to the new and revamped State Coordinating Committee and make sure that they have resources to do such work and to codify it. Okay.
Public and private.
Public and private resources. Okay, the second focus area, we had develop regional partnerships. That would be something that the State Coordinating Committee could probably handle. Is that what we were thinking?
Not just for dialysis, but for all all that we feel fits into this category.
So I wanted to mention that there are some regional bodies out there in this space and coordinating regional transportation. And that's our regional councils, in which we have 2 members here from the Tri-County Council of Southern Maryland and the Midshore Regional Council. And I would perhaps maybe we should highlight some of the work that they are doing in this space since they are already doing regional transportation.
Absolutely.
Would either of the 2 regional coordinators like to respond? Can you pass them the mic, please? Thank you.
If they're going to do statewide coordination, I would be happy to serve on that committee. I do feel like we did a study, we started a program, we understand some of the failings of the program, and we also made some mistakes. But I'd say the one mistake we didn't make, and I wanted to point this out to the people down here that we're talking about a 26% no-show rate. We designed the program so that our no-show rate would be low, and our target was 2% no-show rate. The actual no-show rate that we got was ran between 2 up to 5. As soon as it got to 5, we started working on it to get it back to 2 again. And so that was a result of having a relationship between the drivers and the patients. And I haven't seen any program that generally does a relationship between the drivers and except possibly volunteer programs, which they probably, I would suspect that in these veterans programs, there is a relationship between the volunteer and the actual patient. And that's how you get a low no-show rate. But certainly we would love to participate in some level, and I would allocate time, not just for my staff, but myself to participate.
Actually, I would emphasize the hospital case managers too in our program. I think we had one no-show ride last month. Wow. Okay, so develop regional partnerships for TNCs, nonprofits, period, for community members.
So I think this is where we talked about backing up a little bit and maybe focusing on a state regional hub that supports a wide variety of policy statements and the braiding of the transport methods, workforce development, where as appropriate limit of variation among local jurisdictions. I think we really need to broaden this one and then have a secondary around it all needs funding. And that needs to be, again, codified out of general funds, or that coordinating committee needs to come up with recommendations around sustainable funding sources.
And a technology platform that can sustain that mission, right?
I agree with that. Our first platform failed miserably, and we have a much better one now. But if you're going to do something statewide, you really need one that really works and is big enough, robust enough, and has the ability to expand or contract based on need. So you can't have an unemployment database that needs to handle 20,000 a day. You need one that's expandable. So whatever platform, it needs to be expandable as it goes up, and for, let's say, emergencies, and it needs to be able to contract when you're in a non-emergency situation.
Okay, and then we would also reinstate the MDOT funding that was reduced in '21 due to the CARES Act. Do we have any comments on that? We don't really have some represent.
That's really going to be a tough nut to crack on
transit systems.
Thank you.
Can you repeat that question?
So reinstate MDOT funding reduced in FY21 due to CARES Act. So a number of transit systems across the country received millions of dollars. And they were able to do a lot of innovative things. The challenge will be, how do you continue to operate those things, those programs, those entities? You know, as someone with a transportation background, a lot of times what happens is when you talk transportation, people think roads and bridges and not buses on the ground or facilities that get people to where they need to go, whether it's, you know, healthcare, whether it's work, the whole combination of things. And someone mentioned earlier about one of the biggest challenges, not only in the lack of bus drivers, but CNAs and GNAs, and being able to keep those folks employed. And many of them don't have transportation, so how do you get those folks to, so it's a whole culmination of issues. So we have to really look broad and narrow in, focus in on the things that, but yeah, that'll be a challenge. Not to say that we shouldn't do it, we should definitely do it.
Yeah.
So, yeah.
My understanding is that in what they have, they did a 20% reduction on FY21 because in response to the unusually large amount of federal dollars that came in CARES Act. That money's drying up. At the end of 23, it's going to be gone, and our transit systems, MTA, will have to cope with that if it's not reinstated.
Right. Well, I think the other piece we need to think about is how the 2020 census is going to impact transportation funding in the future. Because census numbers were down significantly. We know at least this year with federal funding that we will be at the same levels, but we don't know what Congress is going to do beyond that. And that could significantly impact transportation dollars.
Right, and you mentioned before about seeing a bus running half empty and another small van running empty. I mean, there's capacity. There's your driver shortage problem. Like, those are really hard choices, but we can't have drivers and buses and driving around not highly utilized. You want to cut back 30% on funding? Well, we can sustain that if we increase efficiency by 30%. But in my hometown, I also see them running empty, and it drives me nuts. So we really have to tackle that head on.
All right, I'm going to say something because I've said it for 5-6 years, and outside of we don't operate buses. We coordinate with two very good systems. Just be real careful, and I totally agree with what you're saying. But be careful who you say that to and the context you say it. From a regional council standpoint, and I know you all deal with it, and I'm sure you all deal with it at a regional council, and we sit in with a lot of elected officials on our local level, state, county, municipality. And we have healthcare professionals that go in and they'll tell their electeds, the bus is empty. I saw a bus driver sitting at the 7-Eleven drinking coffee for 2 hours. They're absolutely correct. Until you find out that bus was running a dialysis patient from 2 hours away in the middle of Hooper's Island into Easton. And that's why it was there, because it was getting paid for that pot of money. And the only reason I'm saying it, we got to be real, and I've sat in meetings with nonprofit organizations that were beating on people up in actually Queen Anne County for this, and I know you've heard this.
Thank you.
And I said, just be careful where you're saying, because what the elected official hears is, I'm paying $300,000 to some organization, or $100,000 to get another $500,000 from the state. Why don't I just dry that up in my little tiny county? I don't want to, our transportation sucks then, so I'm not going to pay $100,000 out of my budget, which is really doing $500,000. So we have to be really careful on how you translate that to elected officials.
Understood.
We all understand it, and I get that, and I'm just glad you brought up the point, because when I've said that, then they go, oh yeah, and we've sat on state committees. We had a rural state committee a couple years ago, right before COVID, and it dealt on a closing of a hospital down on the Eastern Shore. And one of those subcommittees, I ran the economic subcommittee with all the hospitals, but we had another subcommittee that was transportation. And all the healthcare and the mental health that would always call us for our little $60,000 grant that we get to coordinate. Until they find out we don't have any buses, and then, never mind, we were just trying to get money. No problem, totally get it, we love the people the executive directors are working with. But they all got assigned to this bigger committee. 2 years later on the study, they became some of the best advocates in the tent for the healthcare, because all of a sudden they realized, man, what they wanted to do was they're trying to help their patients. I get it, their clients. And it was very easy for years to watch them beat on the transportation providers. When they sat there with these health statewide committees and realized, oh my goodness, it's just not enough money out there. This is what we got. And now we've seen them come in the tent and advocate and back the local transportation providers. We're starting to see a change, even in the local counties where the local electeds, all of a sudden you're hearing the health people talk to the local electeds going, oh no, please don't cut that. So that's the reason I'm saying, just be careful. On a committee like this, absolutely we talk about it, and I totally agree. I just want to because I've seen my own board members sit there and turn, and I'm like, oh man, then we have to go back for literally a month and try to make sure that they don't take $100,000 out of their budget and lose $500,000 out of the state budget to run their people around.
It's that important story behind the data. Most of when we see empty transit buses, it's not because there's not a need. I think there's a need everywhere in the state, and probably every state, for more robust transportation. It's that the transit we have doesn't necessarily meet the needs of the individuals we're trying to serve.
Absolutely.
Because there's not enough financial resources in place.
Yes, and before we just give one moment, guys, we want to make sure that we get covered. We're pretty much wrapping up now, and we want to hear the last comments as well. Want to let Yolanda say something, respond, and then I see Nancy had her hand raised, and I heard Sharon.
Yeah, we have like 5 minutes left. I promised to get y'all out by 2:30, so I want to keep that promise. So we're now moving on to the third focus area, and codified a new health and human services program, transportation program in the Maryland Department of Health that supports interregional transportation, and this would be specifically for rural to urban areas. And urban to rural areas, and yes, both ways.
It could be rural. So my point is, that is one use case, but is there not rural to rural, urban to rural? Like, do we need to have this second part? Yes. We need to have a codified, unified approach.
Let's not limit. Let's not be so specific that we box ourselves in and go, wow, I really wish we had just added the next line to that.
Right. Am I hearing a consensus on this? Yes. A resounding yes?
Yes. Consensus on what?
It's definitely consensus, but interregional transportation, really wanting to make sure that that is clear on what it means, and also that it doesn't exclude other areas or different routes to and from different places. So rural to rural, rural to urban, urban to rural, urban to urban. We want to make sure that it's inclusive.
Interregional statewide.
Interregional statewide. That might work.
But could we also beyond state because there's areas.
Yeah, that is another good point.
Interstate, because there are some areas of the state where the closest medical provider or specialty care provider is going to be in another state, both West Virginia from Western Maryland, Delaware, Pennsylvania. It's a huge need, and that's something that doesn't often get addressed.
Thank you for saying that, by the way. I'm just going to jump in one point. As I mentioned, I drove to West Virginia the other day. Wasn't exactly fun with the snow, the rain, and the sleety. But all that aside, that term senior rides, that needs to be expanded. I'm sorry, I have a
Well, that's
vet.
based on law.
Huh?
That's based on law.
Okay, is that
Yeah.
CARES Act?
No. There's,
It's a specific program.
yeah,
It's a specific funding program.
yeah.
Okay, well, where I was going to go with this. Okay, outside of that, you mentioned something about the 2%, the 5% on the no-show. I can tell you since June, I've only had 2 people that were a no-show. One was a medical condition, and he ended up in the hospital. And the second one was just a cranky person. But all that aside, I have basically, you might as well say 99% I pick up every one of my clients and/or whomever my driver is. So I don't have no-shows. And we need to have the proper funding and any assistance that we can get to make sure that we carry this out as best as we can.
Great,
So-
thank you.
So final comment from me with respect to the whole issue, and I applaud my colleague to the right, with respect to the language that you use in describing services. I worked for Howard County a few years back with a local transit system, and we would get comments from folks saying, well, I see the buses, the green buses, but they're carrying nobody. We were carrying over 1 million people a year. The people we were carrying were people who didn't have other opportunities of transportation, people who were single parents, who had children that they needed to get to daycare, they needed to get to work, and depending on the time of day that you're looking at some of those buses, makes a difference. So be careful with the words that you use and how you describe, because you may end up forcing us backwards and eliminating a whole slew of people who actually really need those services. So
Excellent point. Okay.
Just one comment I'd like to make, just for Courtney and Sharon here. I think one of the things that we got to really look at, and it's a big problem for all of us, okay, and that is how do you work together? And for example, I was up in Frederick County, and they were talking about working with Washington County. And this is what we need to do. If the buses is going half full or whatever, find a way that we could work between different counties and then be able to save the cost at the same time. Thank you.
Thank you. So we want to definitely just bring your attention that the things that you're talking about right now do actually relate to the last bullet, that we just want to get consensus on, or just hear why you don't want to move forward with that one, and then we're going to close out. So Yolanda's going to get the last question, and then someone out here will have the last comment.
Okay, last policy statement we're proposing is increased funding for senior rides to support interregional transportation. Enabling legislation permits up to $500,000. So there is no codification, it just needs to be a budget item. Do I hear a consensus on this?
the Transportation Association of Maryland will be moving this from a legislative perspective this legislative cycle. It is incredibly important. We get a small pot of money from Single Ride. We get, if we get 50,000, we need, 200,000. So we're putting the other 150,000 in there, and we're still not even hitting the bottom of the pan. But again, these are programs that are operated by volunteers who use their personal cars. In Anne Arundel County, we were having some struggles due to the gas prices. We went to the county and said, we need some help. They gave us a grant to be able to give our drivers, our volunteer drivers, gas reimbursement. 98% of the people who receive the checks return them back to us. So these are people who this is in their blood, their sweat, their tears, their hearts. And so we need to be able to support that through some adequate funding. And I promise I won't say anything else today.
Is there, so I'm hearing one comment. Anybody else support this? Do I hear a consensus to support this?
Yeah, that money is worth, that's 10 cents on the dollar.
Yeah.
That's the best value you're ever going to get. Maximize every dollar you can for that service, please.
All right. Well, we thank you all for your participation, your willingness to share your knowledge and expertise in this area of transportation. And if you have any questions, the information is on the screen to contact Yolanda Hixon.